Well, good morning and welcome. I'm Julia Lear. I chair the board for the Coaches Community-Oriented Correction Health Services. Welcome to Health Reform and Criminal Justice, Integrating Jails into Health Information Exchanges. Thank you so much for joining us in this important conversation. We're here today to shine a light on what some would call the unseen healthcare provider, a crucial piece of the healthcare puzzle that is missing from the national conversation about healthcare policy and reform. It's also missing from the conversation around health information technology, a movement that is working to bring more and better health information into our efforts to improve healthcare and to bend the healthcare cost curve. The missing piece, of course, that I'm talking about is the 3,300 local county jails, which serve as a de facto safety net for some of society's most vulnerable members, including those who are poor, uninsured, suffering from mental illness, substance abuse disorders, and frequently are people of color. The jail-involved population has a huge impact on public health and on the costs of both health care and criminal justice. At Coaches, we talk a lot about connectivity, the building of bridges or links between jails and their communities. The goal, our goal, is to create medical homes for jail-involved individuals so that they can get the treatment that they need, be it in jail or in the community. Here are a couple of examples of what happens when you don't have connectivity. A recent study from Emory University found that 55% of U.S. jails, 55%, did not receive any H1N1 vaccine during the 2009-2010 epidemic, and thus more than half of an entire community was excluded from the national vaccine campaign. Another recent report found that people released from the New York City jails were twice as likely as other city residents to die of drug overdose or of homicide, especially in the first few weeks of their release from jail. These individuals are also at higher risk for suicide. So because of no connectivity, we have more disease, more crime, more preventable deaths, and of course, higher cost. For all those reasons, this is why it's so important to bring jails into the mainstream of the healthcare system. Health information technology can help us establish the connections we need. We need to get jails into the health information exchanges. And we need to have jails adopt electronic health record systems that will support the information exchange with their partners in the community. Currently, little of this is happening, but the potential Medicaid expansion of 2014 provides an incentive, regardless of Supreme Court decisions, to focus on strategies for bringing jails into health information technology movement. We need to build connectivity, and we need to build it now. And that's why it's so important to have this conversation today. We have an exciting agenda for you. In a little while, you will see an 8-minute documentary, which I've seen, and I think it will blow you away, The Unseen Provider, Healthcare in Jails. The Robert Wood Johnson Foundation commissioned this production to illustrate why it's so important to get health information technology into all of our jails. Our panel discussions will draw on issues raised in 6 background papers that I believe you all received prior to this meeting. We have allotted time for Q&A at the conclusion of each panel discussion, and we are relying on your active participation. The trusty coaches staff is going to be roaming the aisles with handheld mics during each of the panel discussions, so please flag them down when you want to ask a question. You will also be given index cards, or you have index cards in your folders. If you prefer to write your questions down, please do so and pass them to the center aisle. Just a couple of other housekeeping items. The answer to the most commonly asked question is downstairs and to the right. A second reminder, please silence your cell phones if you haven't already. It will make it easier. Most of you are aware that the meeting is being webcast live this morning, so we can reach as many people as possible. You and your colleagues will be able to replay the video, we believe, as early as next week on the coach's website. So if you want to share that information, we can continue to spread the word. Lunch will be held on the second floor of the Thunder Grill, right here in Union Station, I think you know. You will need your meeting badge to get in, so please wear your jackets if that's where your badge is. You'll find the blue meeting evaluation form in your packet. These are terribly helpful, as I think all of you know, because you've all done meetings. If it would help, start filling them out as you go along so you won't be choosing between getting to the airport and filling out the form. We are going to stay on time. We will move everything along so you don't need to worry about catching planes or moving on. My next task is to say a few words about our two speakers who are going to be introducing the program. They represent the foundations that have generously co-sponsored this meeting. Seema Gajwani from the Public Welfare Foundation and Nancy Barrand from the Robert Wood Johnson Foundation. I want to thank both of them for their ongoing support of coaches and for co-sponsoring the meeting today. Without them, this important work is not happening. Seema Gajwani joined the Public Welfare Foundation in 2007. She is a program officer for criminal and juvenile justice, and mainly in the last 2 years has been responsible for adult criminal justice issues. Ms. Gajwani previously worked in the Public Defender Service in Washington, D.C. Prior to becoming a public defender, she interned with the NAACP, Legal Defense and Education Fund. She also served in the Juvenile Justice Project of Louisiana and the Defender Association of Seattle. The Public Welfare Foundation supports efforts to ensure fundamental rights and opportunities for people in need. In their 60-year history, the foundation has distributed nearly $500 million in grants to 4,500 organizations. Coaches is delighted and honored to have their support. Nancy Barrand is a senior advisor for program development at the Robert Wood Johnson Foundation. Since starting with the foundation in 1986, she has worked on a range of programming concerning healthcare policy research, financing, supportive housing for the chronically homeless, integrating community and correctional health, long-term care, and rural health care. Nancy has helped to develop a wide range of projects across the Foundation's vulnerable populations portfolio and its newer pioneer portfolio. RWJ has emphasized the creation of new opportunities for better health among vulnerable populations with a particular focus on health disparities. We are grateful as well to the Robert Wood Johnson Foundation for its support of this conference and its historic support for coaches. And now, please welcome me in joining Seema Gajwani of the Public Welfare Foundation.
Good morning, everyone. Thank you, Julia. I'm honored to be here, and Public Welfare Foundation is proud to support this event and proud to support coaches. As Julia mentioned, my background is in criminal justice, and I feel like I've had to start to learn a new language to just grapple with some of the issues that you all are talking about here. But in the criminal justice field, the concept of integrating a public health perspective to criminal justice systems and to populations in the criminal justice system is not a new one. It's something that people have been advocating for and encouraging for years and years. But it's really not taken hold in a big and systemic way, really, in many places. There may be tweaks to policy or practice in certain jurisdictions with a limited number of people. There may be some small pilot projects. But the vision that Coaches has to implement massive and systemic change, to bring a public health perspective to this population and to this system is really breathtaking to me. And the potential to divert people at the very front of the end of the system, potentially, from cycling through our jails and to push them into the public health system and address the very fundamental issues that have brought them there in the first place is incredibly exciting and stunning to me, too. So thank you to Coaches. Thank you for your vision and your tireless work. Thanks to Michael and Steve and Nan for putting this conference on and for thinking broadly about how to integrate these two systems. It's your vision that excites us, and we are very happy to be a part of this. I'm happy to share this stage in welcoming you all with Nancy Barrand, who, along with Coaches at the Robert Wood Johnson Foundation, has been thinking about this for a long, long time.
Thank you, Julia and Seema. Welcome on behalf of the Robert Wood Johnson Foundation. Thank you all for being here today. We're very pleased to be co-sponsoring this Coaches event with the Public Welfare Foundation and look forward to working with Seema and the Foundation more in the future. The mission of the Robert Wood Johnson Foundation is to improve the health and health care of all Americans, with particular emphasis on addressing health disparities of our society's most vulnerable members. The Foundation has been working to connect jails to the rest of the healthcare system for a number of years now. Why? Because the population of our jails reflects the health disparities we see in our communities. And without addressing one, we don't think we will be able to address the other. You've all seen the statistics. 10 million individuals cycle through our jails each year. People in jail are disproportionately male, persons of color, and poor. Nearly 80% are considered to have chronic health problems. Upon arrest, between 67 and 86% test positive for one or more drugs. 63% of men and 75% of women in jail exhibit symptoms of mental disorders. 90% do not have health insurance. Many of those who cycle in and out of jails each year rely on our healthcare safety net, the community clinics and public hospitals that primarily serve the poor and the uninsured. Over half the jail-involved population use their local emergency room to receive needed care. Given that the majority, 96% of jail detainees and inmates, return to the community in a relatively short time, connecting the health care received in jails to the health care provided in the community has a direct bearing on county financial resources and overall public health. Jails need to be seen as part of the health care safety net. And health information technology is one important way to create that connectivity, as depicted in the film that you're about to see, which the Foundation commissioned for this meeting. The film highlights the challenges created by the absence of connectivity in the struggling community of Camden, New Jersey. At the same time, it shows the potential of a new health information exchange to address some of those problems. It features interviews with Dr. Farzad Madashari, the National Coordinator for Health Information Technology, and Dr. Jeffrey Brenner, founder of the Camden Healthcare Coalition. Dr. Brenner is well known for his groundbreaking research on very high-cost patients whose intensive use of healthcare services, particularly in hospital emergency rooms, has tremendous impacts on healthcare spending. In the film, he makes the connection between high-cost patients and people who cycle in and out of jail. Watch the film. We would appreciate any feedback that you have on it or other ideas that you may have for how we can frame what is a very important issue. Thank you.
Let's talk about who's in jail. 80% coming in have a substance abuse history. A large percentage have mental health disorders.
They have diabetes, high blood pressure, heart failure, asthma. The list goes on.
For many individuals, correctional facilities are the only place where they're really getting consistent health care.
If we're trying to reduce healthcare costs, if we're trying to improve healthcare quality, this population can't be ignored.
We have to reframe our thinking about the role of jails and the health care that's provided in jails.
I'm an angry family doctor, and I'm sick and tired of patients getting bad care. And my patients in Camden got bad care. I did the best I could to deliver good quality care, but when they stepped outside my office, there were all of these other forces that I couldn't control. The city of Camden is 79,000 people. It is one of the most dangerous cities in the country. We're one of the poorest cities in the country as well. Camden's an extremely violent place. You hear a lot of gunshots in the evening. Camden's where you come to buy drugs.
Camden is a population of people who are working class folks who have the misfortune of not necessarily being able to find work and really have some serious socioeconomic issues.
Most people in the Camden area, one of the poorest areas in the United States, repeatedly return to the emergency room seeking primary care.
High utilizers are folks that are going every day to the emergency room, every day to the hospital. They have very complex medical and social issues.
Many of those patients cycle through the jail, whether it's for 15 days, for 30 days, for 6 months.
We have one woman who comes in all the time who has come back a lot because she doesn't have any of the social supports.
Part of what we need you to do to help yourself, Chanel, is to make those telephone calls yourself.
Okay. They're severely mentally ill. They don't have Medicaid.
I'm sorry, love. Have you gone and talked with any of the therapists that we asked you to talk with?
They've exhausted some of their welfare. Their family can't lend them the money they need for any type of medication.
Last time when we went, they said somebody canceled the appointment.
How can you really manage your diet when you have diabetes and you're homeless and you don't have any money for your medication?
I'm going to check in with Dr. Byrne, okay? And I'll bring you back the info for the therapist.
These are really some of the most vulnerable populations that need the help the most, and they're part of our communities.
Over the years, we found that a significant number of the patients in Camden that are going to the emergency room and hospital over and over also end up in jail as well. The jail is a whole nother part of the healthcare delivery system.
Let's say I'm unstable when I come in the door. Somebody has to identify what my real condition is.
Are you under the influence of any drugs or alcohol?
My real diagnosis and my real medication.
You have a serious illness.
Might be trying to call the various pharmacies to see if they have any records of this person. Most jails are still operating with hard copy medical records. You've got rooms with volumes and volumes of paper records.
They do CT scans, they do MRIs, they do very costly procedures to try to figure out what is going on with this inmate. All the while, the person is decompensating, the person's getting worse. They could be really wreaking havoc in the jail and causing a lot of extra security, a lot of resources being spent trying to solve a mystery that is a couple clicks away.
About a year and a half ago, we went live with a system that took a lot of work to put together, and it's a health information exchange.
Health information exchange is basically a big database of information.
It is a web-based view for any provider in the city that ensures that doctors and nurses and health providers have seamless access to people's medical records.
It feels fantastic to know that I can look in the computer, pull up the labs or the report, and do whatever the next step is that's needed for their care. But the HIE hasn't been extended to the jail systems.
Right now, there's no communication between primary care provider and medical staff in the jail. Literally, the jail is cut off from medical society, so that patient disappears.
We often have no idea what's been done for them when they're in jail, what medications were started in the jail, and what new medical problems occurred while they were in the jail. So for the provider community, this is incredibly frustrating.
That disconnect is tremendous, and it has serious implications across the board. It increases the overall cost to the jurisdiction, because now I'm paying double. I'm paying for something that might have been done in the community, and I'm paying again for it being done in the jail.
I find it, mind-boggling that we can transplant organs and do open heart surgery, but that we can't do simple things like share data.
The overall goal here is connectivity. We're trying to create bridges from that island, which has been corrections, to the community.
If they had access to the HIE within 2 minutes, the intake staff could really get a good understanding of this patient.
It simplifies the screening and intake processes, provide real-time information with regard to pharmaceuticals. There's a direct healthcare benefit. It improves public health.
The HIE is helpful in a primary care office. It's critical in the jail.
I think the value of health information exchange is rising with accountable care and the new models. But once you have the cost and benefit equation right, information can flow at the speed of trust. What it's going to really take are leaders in the correctional facilities who can blaze the path and demonstrate it and talk about it and show others how it's done.
The story of healthcare in America is really that good doctors and good hospitals go to work every day and deliver a disorganized and fragmented product. We're taking really vulnerable sick people and not taking good care of them, and we're spending a lot of money in the process. I can't think of a bigger ethical and moral catastrophe. We're going to be in a terrible moment where we either ration care or we fix the delivery system. Figuring it out, one patient at a time, one jail at a time, one community at a time. Embracing patients who have been in jail and been in prison is the right thing to do as a society. And it's a smart thing to do.
Hello, my name is Ben Butler. I'm the Chief Information Officer of Coaches. For those who are interested, this video is available through a link on our website on the homepage under the What's New section. Of course, it's being called the Unseen Provider. Just click on that. And when you go back to your offices tomorrow, you can have people view it with you. I would like to thank the Robert Wood Johnson Foundation for funding this video. Before I introduce the next speaker, I would like to remark on how well the video we saw lays the foundation for this panel discussion. Jails and healthcare are complex topics, but when we combine these topics, their complexity grows greatly. What we just saw in the Unseen Provider was a small part of that complexity. When I first started working with coaches, I envisioned that health care delivery in jails would be analogous to primary care facilities. But health care in a jail is not so easy to categorize. and it is certainly more complex than a primary care facility. Healthcare systems in jails are more like complex medical delivery systems that in large jails often include infirmaries, which in some cases parallel an inpatient facility, primary care and chronic care, and specialized mental health and substance abuse units, which are similar to partial hospitalization programs. Another challenge of categorizing healthcare systems in jails is that typically primary care practices do not have in-house pharmacies, but jails frequently do. Thus, jails need to keep track of medications that are prescribed and dispensed. Besides all these multiple health care delivery systems, jails are most importantly a place where custody and control and safety come first. As you have read in the paper, implementation of an electronic health record in the New York jail system, the EHR at Rikers Island was the electronic health record system that the Primary Care Information Project selected for participating primary care providers in New York City. This EHR was suitable in a primary care facility, but had to confront many challenges to be useful in a jail environment. To speak to these challenges, I would like to introduce Dr. Homer Venters. Dr. Venters is the Assistant Commissioner for the Bureau of Correctional Health Services for the New York City Department of Health and Mental Hygiene. In this capacity, Dr. Venters directs all aspects of health care in the New York City jail system. Dr. Venters received his MD from the University of Illinois, completed his residency in social internal medicine at Montefiore Medical Center, and a fellowship in public health research at the New York University Langone Medical Center. Dr. Venters is also a faculty member at the NYU Center for Survivors of Torture and co-chair of the ICE NGO Health Advisory Group, which advises the U.S. Department of Homeland Security on medical care for detainees. After his speech, Dr. Venters and I will join Dr. Stephen Summers in a panel discussion. Stephen Summers is the President and Chief Executive Officer of the Center for Healthcare Strategies, which he founded in 1995 with a major grant on Medicaid managed care from the Robert Wood Johnson Foundation. Before starting the Center for Healthcare Strategies, Dr. Summers was an Associate Vice President and Program Officer at the Robert Wood Johnson Foundation. Prior to that, he was a professional staff member for the U.S. Senate Special Committee on Aging and legislative assistant to U.S. Senator John Hines of Pennsylvania. Dr. Summers serves as a visiting lecturer at Princeton University's Woodrow Wilson School of Public and International Affairs. Dr. Summers earned his PhD in the politics of education from Stanford University. Please welcome Homer Venters.
Thanks. I'm just going to talk about 8 minutes. Is that okay? Great. Good morning. I wanted to say first thank you to coaches, to Steve, to Ben, to all the other coaches, folks who have put together just a fantastic day. It's very, very impressive. I also wanted to thank and recognize my colleagues from New York, Dr. Summers, Cecilia Flaherty, Rick Stazeski, who's sitting right here on the aisle, who is the one who did most of the hard work to get this EHR rolled out on the island. And so he, more than anybody, deserves accolades for the attributes of the system. And the clinicians, like myself, probably deserve the knuckle rapping for the shortcomings. So we, in 2008, started rolling out an electronic health record, ECW, in the New York City jail system. So as you probably know, it's a big jail system. It consists of 12 different jails now. It was 11 at the time, but it's lots of jails that look like medium-sized jails, 9 of them on an island and a few others in the boroughs of New York City. So it's a pretty complex and fragmented correctional health system, so it's up to the task of mirroring our healthcare system writ large in the community. So we started with the women's facility in 2008, November 2008 at the very end. Implemented, went live with the EHR there, and then we rolled it out across all of the other facilities through the spring of 2011. So As Ben just mentioned, you all know very well, I think most of you, what all the different types of care provided in correctional settings are. I think that the thing I would say about jails and our jail, I think in particular big urban jails, is it's incredibly chaotic. And so we have lots and lots of intakes being done. In our system, unlike others, this is a several-hour process. It looks like a hospital admission and physical, so it's done by an MD or a PA, and it takes several hours. We do all sorts of work with universal offer of HIV, with vaccinations, screening for mental health issues. So this big process then was switched over to our EHR, and I think was probably one of the biggest challenges for us. In addition to intakes, we have ambulatory care, follow-up visits that are very common in jail, sick call, emergency responses, infirmaries. We also have a communicable disease unit that functions to rule out TB, and where we send folks with like varicella isolation. So we have lots of different types of healthcare that we're providing. ECW, as you may or may not know, is a very solid ambulatory care product that we and Rick worked very hard and continue to work very hard to adapt to our system. So to the extent that the type of care we provide mirrors what ECW was built for, it's been a pretty good implementation. I think the farther we get from that, the more we get into things that don't look like ambulatory care, the more we did run into challenges, and we have worked and continue to work on ways to modify the product and in some cases modify our workflow to work it in. I think anybody who's considering an electronic health record will ultimately contend with this notion that some of your care delivery will have to change in order to accommodate the product you get. I think that that's one of the key lessons for us. I think two other lessons I want to impart. One is that the EHR, whatever it is, will shine a very uncomfortable light on some bad clinical practices that we have, that you have, that everybody has. So we spent a lot of time thinking about how do we get a team together to train our providers, to go live, all the process and logistics associated with implementation. What we didn't expect, and what I think continues to surprise us every time we implement any new technology, is that you find out all sorts of things you're doing clinically that don't make sense, or that you thought you weren't doing, or you need to fix right away. And so it creates this huge challenge for the clinical leadership to not only work with your clinical staff to get ready for this new change and accommodate the new change, but all of a sudden you find out you're doing blood pressure readings the wrong way, or you're not prescribing what you should be prescribing, or you're responding to emergencies without ambu bags half the time, because now you can look at the notes and find out, holy crap, you went to the housing area with no ambu bag for a patient that was down, and it's right there for you to see now. It's not secreted away in a paper chart. So that is the second lesson I think I would impart to you, is that it really shines a light. So get ready for your clinical staff to do lots of work that's purely clinical as a result of having implemented this new technology. And the third is that I think it is not, for much of our work, it is not a net gain in productivity. Some of the tasks, and particularly the tasks that happen in corrections that are process-oriented, that are laborious, those will become more laborious for many of your clinicians. And I'm sure it depends a little bit on the electronic health record you select, but if you take something like intake, which is a very process-oriented, you're triaging, you're looking for people who might go into withdrawal, or people with heart conditions, or insulin-dependent diabetics. You're looking for a small number of patients, but to do that, you're doing a lot of work, a lot of routine interaction. And in those settings, we find that the health record, people who are very, very good at intake, either PA or MD, who could do, let's say, 10 or 12 in a shift, might have gone down to doing 8 in a shift, or 7 or 9 in a shift. And we haven't gotten back to, they certainly have not gotten back to the level of productivity they had before. There are other areas where we've had a gain in productivity. Some of the ambulatory care venues, I think, are a little bit more efficient, but I think that I would caution that, all the different, everybody in this room has very little margin for extra work, right? You have slim budgets. They're smaller this year than they were last year. You have fewer staff this year than you did last year. You probably have just as much work to do, if not more. And so as you contemplate rolling out an EHR, it's important to realize you will need to redistribute some of your resources to accommodate the productivity consequences or implications for the EHR. The final thing I wanted to mention is the EHR has great benefits, and I think we, in our healthcare endeavor, think about correctional health, certainly with regard to connectivity to the community, which is coming, and there are lots of folks in the room who know much more than I do about it, but we certainly look forward to that, to connecting this amount of information to the outside. But for inside the correctional health system, we have these three frameworks we think about for how we deliver healthcare. So the first is patient safety. And this is something that's very well known to most people in correctional healthcare, certainly people in the community. So thinking about, do we deliver medications the right way? Do we find out about adverse events? Do we have a way to monitor and record doing things the right way or the wrong way? And so an electronic health record certainly is a boon to that mission, to promoting patient safety. You can read what people have written, you can see when something was prescribed, you can find out if it was delivered or not, so it's really a big plus. A second framework we think a lot about is public health. And so how does the health of the population in front of us and their back and forth with the health of the population in the city, how are we doing there? And so tracking things like outbreaks or the incidence of different diseases, or overall how are we doing with our diabetics? Are we increasing, how are the A1Cs looking? Are we getting more finger sticks done? That type of population health or epidemiologic approach is really important. EHRs are really important to promoting that in corrections. And the third, which is I think far afield sometimes for us in corrections, although certainly not for our colleagues in Europe, is human rights. And what I mean by that is we in our systems have people that are not just high utilizers of care, but who are vulnerable individuals. And they're vulnerable by dint of being part of a group. And that group may be the people who are mentally ill, it may be people who are LGBT, it may be people who are a different color or a different gang or whatever. And in our system, we provide a lot of care and we do a lot of things. And so those first two frameworks of patient safety and of population health and epidemiology, I think those are really key. But I think the thing that the electronic health record, surprisingly to me, helps us with is to keep track of, are the people who slip through the cracks slipping through the cracks? And are we as providers doing an ethical and moral job of finding them and of advocating for them and of making sure that our position and our relationship doesn't get pushed off its mission? This problem of dual loyalty that every one of us in corrections faces, that we answer, even us in New York City where we answer to my boss as Commissioner of Health. So we theoretically don't have this, but we work in a security setting. I think, as Ben just said, security rules the day. So the electronic health record provides a venue to keep track of our central mission, which we're there to care for patients. We're not there to clear bodies for security. We're not there to help the sheriffs or whoever the custodial or security staff. We're there to care for those patients. And so to the extent we can build, and we have built, we're just starting to build some tools in the electronic health record to find vulnerable populations, to find out, are they doing well? A good example is injuries, trying to find the rates of injuries among different groups, and others, people who go into solitary settings, the mentally ill who sit there, to come up with specific note and visit types that let us know when somebody's decompensating. We're just starting to think about this, but those three frameworks, patient safety, it's a clear win. The second, population health and epidemiology, I don't think you can pursue that mission without an electronic health record. And then human rights, I think here in this country, we really need to get comfortable with the terminology and the language around human rights. And I think that electronic health records, paradoxically, are a venue for starting that discussion. So, thank you.
Thank you, Homer. Thanks. Homer, in your paper you stated that one of the benefits of the EHR was that the providers in jails could view the inmates' health records from previous incarcerations. How would it change the practice at Rikers if you could fill in the gaps and see the health records generated between incarcerations?
I think there would be two big gains. I think the immediate gain that we can all think of is all this work we do on intake, all these labs we order, or medications we prescribe, we can do much less work and much more intelligent work on behalf of the patient. So we wouldn't need to get an A1C on everybody and a CD4 and a viral load and all of the incredibly expensive labs and tests we order. I think that, though that speaks to a much bigger gain and a much more fundamental problem in corrections, which is I can't tell you how many M&Ms we're at, and we just, at the end of the day, are saying, how come we can't get our providers to look at the patient in front of them and pay attention to them, right? Like, are they getting worse? Are they getting better? Part of that is we create this barrier for our providers. I mean, we ask them to do all this crap on admission, right? Like, our admissions are hours long, and we do this and this and this and this and this. And to the extent that we can, like, make this less of a rote process because we have information from the community, because we can immediately sync up. If I'm doing an intake on somebody, I'm finding out what goes on with them in the community. I know what their A1C is. I know them as a person. You know, I'm thinking about them as an individual. Then I think it helps us on this much more broad mission of paying attention to the patients as they're in front of the providers, because we're not just every diabetic gets this and every person with HIV gets that. And I think and it also obviously is a huge boon to the patients in the community because we can continue their care and their medicines, but it's just something we absolutely have to do. It's a complete mandate for us to figure out how to do it. I'm glad there are smart people who are figuring it out, and I think it will radically change the type of work, the amount of work, and my hope is the interaction with our patients in our settings.
Steve Summers, if the Supreme Court upholds Medicaid expansion, how important will it be come 2014 that jails are connected to health information exchanges?
Well, I feel like I should step back just a second and say where I'm coming from. I feel a little bit like Seema when she said she was learning a whole new language, and Steve Rosenberg and you are all exposing me to the other side, the Department of Corrections side of this discussion, or the corrections side of the discussion. And so I feel like I'm here kind of as a connector. I'm not a clinician. I can't speak as eloquently as Jeff Brenner, certainly, or there are a federal official who's writing the laws or interpreting the laws. And I'm not even a Medicaid director, but I do work with a lot of Medicaid directors and with folks from health plans. And from that vantage point, I'd have to say that this is an incredibly important opportunity because, as I think Nancy Barrand eloquently outlined, there's so much overlap between the Medicaid expansion population and the population that are seen in the jails and that are cycling through 9 million, 10 million unduplicated count every year, and the characteristics of behavioral health problems, substance abuse problems, all of them will, or almost all of them, will be eligible for Medicaid in 2014, Supreme Court willing. And right now, the system between, as Jeff Brenner was saying, the system between healthcare and the jails is disconnected. Unfortunately, there's a fair amount of disconnection already in the health side between physical health and behavioral health and substance abuse. And the HIT systems that are being developed are better on the primary care side by far than they are on the on the behavioral health, particularly the substance abuse side. So there's a lot of work to be done on both sides, but the connectivity issue, as Homer was saying, is huge because you're losing track of all kinds of information that's very valuable for managing the care of people whose care needs continuity more than almost anybody else.
I know prior to this conference, you had an opportunity to go to Rikers and see the systems in New York City, which they've implemented. How do these systems fit within the overall paradigm of Medicaid managed care plans?
Well, I was very, very impressed by what I saw at I guess it was the Tombs, right, and the jail system in New York. And I also visited Camden, so I've seen both, and I've seen that there isn't the same capacity, certainly in Camden, as Jeff indicated, as there is in New York. But what Homer and his colleagues are trying to do in New York on the corrections side is what you would hope that managed care organizations across the country are doing on the physical health, and to the extent that they can get connected to the behavioral health side. They want that information in order to manage the care of their beneficiaries, because if they don't do so, and if they don't have the data to know what's going on and what drugs have been given, what care has been provided, they're likely to see these people that are going to be enrolling in their plans in 2014 run through emergency rooms and hospitalizations in the same way they currently do. And that's obviously not something that healthcare executives, managed care executives want to see happen, because those are avoidable costs in their eyes, and information systems are incredibly important to that. And some of the managed care organizations in Medicaid have developed very sophisticated information systems and capacity to extract information to help manage the care, particularly of their high-cost, high-need beneficiaries.
Do you have any thoughts on managed Medicaid, Omar?
No, I would.
You would.
As Steve eloquently stated about corrections, this is a field I'm just learning about, which is why we have in-house experts with us today.
Okay, yeah. Didn't mean to put you on the spot, but if you want to contribute anything, feel free at any time. And about integrated data systems, Steve, can they increase the comfort level of managed care organizations in engaging with this jail-involved population, which has been mostly invisible to them?
Yeah, we had a meeting in Washington about, I guess, 3 or 4 months ago with you, and we invited several health plan officials, United, Aetna, some Medicaid-only health plan officials. And to say comfort or enthusiasm would probably be a slight exaggeration in this regard. However, as was pointed out earlier, the population that is cycling through jails has a lot of the characteristics of populations, certainly on the serious mental illness side, that some of them have had to deal with. Not that physical health and behavioral health is as integrated as it should be. But information systems and data and being able to predict what is likely to occur and to be able to direct interventions toward those that most need it will give them more comfort. And to know that there aren't reams of paper files, as was depicted in Camden, as opposed to electronic information, as Dr. Bender has described in New York, would be comforting to the degree possible. And I appreciate in your paper and in your remarks the degree to which it isn't perfect on your side yet, and haven't gotten pharmacy integrated, et cetera. But it certainly isn't perfect out there either in the healthcare system. And at some point we'll probably get to what's the capacity of community-based behavioral health providers, particularly on the substance abuse side, to generate anything like electronic health information.
Yeah. It is pretty amazing to see the system in New York. Homer, since the EHR has allowed you to track aggregated data on medical conditions from which you can see certain patterns emerging, has the tracking of injuries created tensions with security?
Yes. I think that, we have been paying a lot of attention to injuries for a couple of reasons. I think, first of all, it accounts for a lot of our work. I think anybody who works in corrections, particularly in jails, spends a lot of time on injuries. I think that also it's something that happens to people. So we are very keen to articulate this notion that most medical problems that people come to us with, by and large, get better while they're with us. That's not true for everybody, and that's not true for every condition, and there are things we struggle with. But injuries represent one of these things that happen to people. They didn't come with this injury, and they're in the system, and that happens to them. And part of it is that we put a lot of work into caring for injuries and tending to injuries. But part of it is we need to think about, if we're the medical providers in a system where a bad health outcome happens to people, it's our responsibility to find out about it. And so it has created a fair amount of tension, but I think that it's part of this third, I don't know, it maybe falls into patient safety and population health and human rights, but these are our patients. And so if they get injured in our system, we need to find out why. Now that we have a structured template that every time somebody who's injured is seen by one of ours, it's about 1,000 times a month in our system. So between the second and third most common injury type, because we put in all these structured data fields that the CDC uses to track injuries, and month to month is either the second or the third most common. But a couple hundred times a month, we have a slip and fall. Nobody in this room really believes that people are slipping and falling at that rate. And so even more alarming than just injuries happening to our patients in the place we work. I mean, you think about what goes on in an incident report when somebody slips and falls or whatever happens in a hospital, is that the second or third most common type is something we have no idea what it is. We could speculate, right? We could say maybe these people got beat up and they didn't want to talk, or maybe they were like goal-oriented and laid down on the floor, but we don't know. And so the EHR provides us a venue to get more detailed and reliable data about this so that we can think about how do we prevent injuries, who are the vulnerable groups, you know, LGBT patients, patients who are mentally ill, patients who are in solitary confinement, they're at high risk based on the data we're starting to accumulate. So yeah, that creates a lot of friction with security, but you know, our job as the health providers is those patients. It's not security, and we conform to security and we accede to their rules, but it allows us a structured, reliable format to come up with data and say, this is happening to our patients in this setting, so we have to figure out a solution.
In my introduction, I talked about how healthcare in jails is difficult to categorize and how there were challenges of fitting what was an EHR designed for a primary care practice into a jail environment. Would you care to elaborate on fit issues that would give the audience an idea of how complex healthcare can be in jails? Because it's a very mixed group here today.
Yes, emergencies is a good example. So we probably have 20 to 30 emergencies across our system a day. So many of those emergencies, people will respond to a housing area. So, you know, a doctor, a nurse, a PCA or two grab a bunch of equipment, they go out to the housing area for a man down or for somebody in distress. So all that's going on out there needs to be documented. So they get there, they take vitals, there's some record of what's going on. So when you start with an ambulatory care EHR, most of these are visit-based, where you're, like when we started with our EHR, you know, we're scheduling visits and people are like, you're coming to the doctor's office, they come to the doctor's office, you're clicking on a visit that's on a calendar, you're then, the provider's merging it in and they're sitting down, the nurse or the doctor. And so if you think about in an emergency, so you have medical contact out in the housing area, you have along the way, if you do some sort of intervention on the stretcher on the way back, and then you get into the clinic, you know, somebody who has, let's say, a stroke, you know, they may have like 5 sets of vitals in a very short period of time. And so in a format that's really structured for like, you see the nurse once, you see the doctor, boom, you're done with your clinical encounter. It can be tough to shoehorn that in. Now we have, with Rick's help and ECW's help, built in lots of ways to accommodate that. I think the other thing you referenced was infirmary care, where we have round the clock. You know, we have 100 men and about 30 women very ill in a setting with 24/7 nursing and doctor care. And so it's really difficult to document all the different types of things like wound care, you know, vitals checks, neuro checks, things that the ambulatory care record is not built for. But conversely, the inpatient records would provide the same challenges for what is the bread and butter is our ambulatory care setting.
Could I interject, Ben? Because
sure.
I did, as you pointed out, I did get to visit Rikers and see the clinic and see the process. And as someone from outside and who's concerned about the fact that all of these individuals are going to become Medicaid eligible and they're going to become part of the Medicaid system, getting that picture across to the stakeholders with whom we work generally would be pretty important. So, Nancy, I don't know if you want to do another film, but Camden is one picture. The what's going on in New York, and you were there, is another, because of the robustness of the activity within your health system inside the jails. I don't think many people in Medicaid or in the Medicaid stakeholder community know that. They just don't realize that, and so that's good news for them in some ways. It'd be particularly good news if there's more connectivity generated between the two sectors. And I work with Medicaid directors across the country, Medicaid leaders, who for the most part don't know about this population that we're talking, just don't realize that this is coming. And it could be 4 or 5 million, you know, people that have serious issues that also have jail issues that they're going to be responsible for, and just getting that information out in front of them so that they're more aware of it and aware of the demands that might be associated with that, particularly to connect to the departments of corrections, et cetera. That's a very valuable piece of connectivity that's going on in this meeting.
Steve, I know in our last conference, November 17th, 2010, we often mentioned David Mancuso's studies from Washington, D.C. How will health information exchanges in jails better enable evidence-based treatment?
So I didn't tell you that I was a little perplexed by how to deal with this question that you had fed me beforehand. Thank you, Ben, for doing that. And I'm still a little perplexed because evidence-based, and I should defer to you, and I will defer to you quickly, evidence-based treatment for people who have multiple comorbid complex conditions, I don't know if that's an oxymoron or, I don't know if it exists. So that's why I'm somewhat perplexed by the question. Now, we know that care management is critical. We know that transitions in care are incredibly important to pay attention to. But beyond that, what's the evidence base? Please, Dr. Ventures, help me.
Well, I think the EHRs have a variety of tools that can really assist clinicians. So the clinical decision support tools, which are part of the meaningful use rubric. But I think that even things as simple as structured templates. So one of the vexing, infuriating for medical directors issues is when people is helping your clinicians differentiate between a hypertensive urgency and hypertensive emergency. So if somebody comes into your clinic and they just have super high blood pressure, but they're fine, that's called hypertensive urgency. And it's not an emergency. You don't need to hit them with all sorts of medicines that are going to drop their blood pressure to the floor and make them faint or make them have a heart attack. But we consistently would see people come in with a sky-high BP. They get a medicine that's going to drop this medicine clonidine that makes us crazy. People get it. Their blood pressure bottoms out. They faint or they get a little ischemic or, they have a bad adverse effect of this. And so we have built templates into ECW that in these settings hopefully guide the clinicians to think about, is this a hypertensive urgency or is it an emergency? Do they have some symptoms like they're seeing spots or they have a horrible headache or something, or they have some protein in their urine, to help them track between these two? Because I think that in our settings, we're most concerned with these life-threatening emergencies. And there's everybody knows algorithms around acute coronary issues. So in the hospitals, in the EDs, every doctor out there knows, like, if you think somebody's having an MI, you do ABC. But there are many other emergencies that happen all the time where we want to assist the providers in what is an incredibly chaotic setting where, like, the patient's screaming, the officers are yelling, you're in a clinic, it's hard to keep track. The EHR should help them with those tasks of, like, let's stay at, is this our frame of reference or is that our frame of reference? And if this is our frame of reference, what are the things we want to make sure we do?
It's very interesting because when I started going to jails many years ago, it is that trying to control the chaos that was most salient. So now I'd like to have the audience participate and ask any questions of our panelists if they would like. We have people here with microphones, so the people with microphones, if you could raise your hand, and they will, the participants are raising their hands up here, please.
Thanks. Bob Bilecki, Cumberland County Jail in New Jersey. I was wondering if you could give us some advice on getting ready to go to electronic records. We have shared intelligence for many, many years in the jail community throughout the state and sometimes nationally. And we're running into problems even after we've been doing this for a long time with everybody doesn't have the same IT system. So we can't share, we have the information, but everybody's doing their own thing. I was just wondering, did you have that experience when you rolled this out in New York? And was it a problem that different people bought different systems and then you couldn't talk to each other? I don't want that to happen.
Well, I'm sorry to hear that because it will happen. But yeah, we did have that problem, and I think that there are multiple ways. Every one of these electronic health records has a medical summary. For instance, we send people to the state DOC system all the time, as all jails do, and so we still actually use this handwritten state transfer. It's a medical and a mental health summary because we're still working on getting the EHR to produce a summary that we think is exactly what we need. So it's an important consideration. I think that no matter what EHR you adopt, though, there are all these swirling around. Rick is kind of the master of all these for us, but all of these different ways that health information exchange is being explored and promulgated. And I think that what you really have to do is think about who are the people you share information with the most, and then come up with a plan with them. So for us, we have a monthly meeting with the state DOC, and so we know we're on board with them. They know that we have this electronic health record, that we're still going to use our old system of sharing information, and that we're moving towards something else. And I think that inevitably, there will be some very low-tech solutions that you have to just persist with for a little while, but the goal is to get rid of all those. And so I think that all these electronic health records can produce something called a CCD, which is a little medical summary, and that's good for the community and sharing. It's a standard medical summary that I think CMS, some federal authorities have blessed as appropriate. What's important to know is that leaves out a lot of mental health information and substance abuse information. So your patients and our patients, the two most common diagnoses are a mental health diagnosis or a substance abuse disorder. So, it's important to think about as you buy electronic health records, pretty much none of them off the shelf are going to really accommodate sharing that kind of information. They're going to get the meds and they're going to get the diagnoses that are on, the problem list, but they're going to miss a lot of important information about Axis 4 or 5, or, is it substance abuse or is it substance dependence? And so I think you basically just have to prepare yourself and allow for the fact that you won't be able to share information seamlessly, and then figure out who your key partners are and just come up with a plan.
I would just like to add, when you hear acronyms like that CCD, Continuity Care Document, Coach's staff has prepared a glossary, which you have in fact, that acronym is in the glossary, so if you're a little lost, feel free.
Because I forgot.
Yeah, it's easy to forget the acronym. Next question, please.
Yeah, hi, I'm Joan Randell from the Nicholson Foundation. I have two questions. One, I just confirmed with Rick, who I know from New York, that most of your patients are on Medicaid. Previously coming into the jail, and of course, so one of the things I was thinking of is, as the Department of Health, you could get access to the Medicaid Management Information System. You could, although there's a time lag, maybe 6 months or so, you could look at the diagnoses that people have and where they were treated. So that would give you something, and you could probably just print it out. And I used that with a project that we had in New York, and it was incredibly helpful. And it also had mental health and substance abuse information. So as an interim, before you have your HIE, I think that might be something that you might want to look at. Second thing I wanted to say is, since the people already on Medicaid, I was surprised when I asked Rick if you don't bill Medicaid for their services, because you do the intake immediately, pre-adjudication, predisposition, right? So you don't know?
No.
Oh, post-arraignment. I see, but in some jurisdictions, they do bill. New Mexico, Pennsylvania, and the feds have allowed it. So a lot of you are talking about, people are talking about when, if, everyone's going to get on Medicaid. In New York, everybody's on Medicaid because of the 1115 waiver. But in 2014, in other places, the prohibition, if somebody's incarcerated, I haven't heard anyone say that that's going to change. So why do you think, there's this discussion that it's going to be so important, but what really is going to change unless that piece of the Medicaid regs are changed as well?
So I'll defer the regulation question and answer the first one, which is, you're right, there are existing pools of information that could be incredibly valuable to us. One of the things I didn't mention in my remarks, which I should have, is One of the kind of dispiriting aspects of rolling out an EHR is that just because you have the information there, people are not going to necessarily go look at it. So we had always contented ourselves with the fact that our old systems, the reason people never found out that the guy was here 2 weeks ago and had this and that, and this was a diagnosis, was because it was hard to do. Well, we've now made it easy to do, and still, often it does not happen. And that's, that's with having a right pane that opens up, that says, this is the problem list, right? And so all the problems on there. So look at these problems that are directly in front of your eyeballs and tend to some of them. And a lot of the times that happens. But I think that the thing that we're very cautious about is that it's our experience that particularly on intake, that's chaotic, that's fast, that you want to get done, where it is important to find out that information. Was somebody on an atypical antipsychotic 3 weeks ago? Because you know what? That's a patient we don't want to mess up. That is also the same system that is so chaotic and so time sensitive that we just have this process driven thing. People are trying to get through it like it's like they're working a shift. And so in the individual encounters, like a mental health intake, like a chronic care visit for something, those are the venues where we can make use of some of these pools of data. But on intake, we have struggled to get people to use the information that they have actual direct access to. And so we're sometimes a little cautious about expending huge amount of efforts to link up with other systems. Even though you are right, it should bring great benefit to our patients.
And before you defer to me, because I'm going to defer to somebody else, on the Medicaid regs, what is striking in New York as well, you're embedded within within the health system for the city. And yet, and there, I think, Joan, in New York, there's a suspension of Medicaid, not a termination of Medicaid. Yet, I don't see that there's a lot of Medicaid billing going on within any of your jail system. So that begs your question, and that is part. I mean, people talked about the theme of connectivity here. I think there's also a theme of discovery here. We're in a discovery mode, trying to understand, certainly on the Medicaid side, understand what the opportunities, obligations are with respect to this population. And I don't know that New Mexico and or Pennsylvania, which you cite, how much of that is going on within the respective states and how public they are about it, and whether they tell people in Washington. Yes, thank you. I thought so. So we won't talk about it anymore. Erase the tape on that. But I think it is a direction that we will keep pushing forward toward, and there will be more known as we get there. And there are other people in the audience, if they wanted to raise their hand, who could say more about what the law says about coverage of people in jail, pre-adjudication, et cetera. But it wouldn't be me that would give you the best information on that.
I think Dr. Summers is our in-house expert, so what can you help us with this question?
Microphone, please.
Unrelated, Dr. Summers, right?
That's right. That's right, completely.
Thank you. Good morning. Oh, I just knocked my glass over, excuse me. Yeah, I mean, I think it's still unclear, you're right, about whether we're going to move to a point that pretrial detainees in jails can actually bill for Medicaid. And I think that there's still a lot of work to be done. We'll continue pushing there. It's actually very complicated. While I think that we would like to be able to have that option, I think, as many of you know in this room, probably more than most of the people driving those discussions sometimes, being allowed to bill Medicaid does not mean that you are eligible to actually do so. I think that would then require a huge amount of effort on all of our and others' behalf to get a lot of jails up to the point where they can actually bill for Medicaid. But I think the important thing that I find so exciting about these discussions that we're having is as the country is moving towards recognizing that we have to really make some seismic shift changes in how we how we're doing care for the most vulnerable and then the most expensive patients. Correctional health is actually being inserted into that dialogue in these early stages. And I think that's where it's crucial for us to keep the dialogue going, because it's not only about the few people, most of whom are in this room, who care about incarcerated populations, who are really going to move this, but it's incorporating. It's being in a position like New York City, I think, is kind of leading the pack on, that allows us, with having an electronic health record, to be able to offer data instead of just yell and complain and say, we know how sick our population is, we know what their Medicaid expenditures are, we know what their preventable hospitalizations are, we hopefully soon know what happens to them when they leave our custody and what happens when they come back. And I think that's the way that we drive change to those outside of the jail and prison communities.
Hi, I'm Jan Root with the Utah Health Information Network, and I have to admit that I'm on the tech side, not the correctional prison side, so I'm learning a lot of new acronyms today, which is great. I just had a question for Dr. Warner. I know that New York City has a number of HIEs. I have spoken with them many times. And you mentioned that you're in conversations with the Department of Corrections about exchanging data, I guess, within the correctional system. Have you talked with the HIEs?
Sure. Rick Stazeski, who's right here next to Dr. Summers, is our point person, but we have, the plan is for this statewide Rio system to go live soon in New York State, and we will be theoretically pushing data into that. I don't know who else will be pushing data into that system, but we have, as I mentioned, Rick could probably list 6 or 7 different ways that he and we are exploring the data exchanges through the HIEs and through other mechanisms as well. And I feel like, in 2008, it was a certain crazy world, and everybody was snapping up these EHRs in the community. And now in the community, you look around, and some of those EHRs are there, and a lot of them are gone, and a lot of the things people hoped for those did not happen. I have this kind of similar view towards all these information exchange possibilities right now. It's incredibly exciting and heartwarming, but I think really none of us knows which of those things are going to be alive in a year or 6 months, or who's going to dominate. And so I think it's important to put effort and energy into your basic tasks, which is taking care of people in your system, and an EHR is a good way to do that. I think you need to devote some resources to the health information exchanges, because that is definitely going to help you. But I think it's difficult to ascribe, it's hard to pick a winner right now.
Yeah, when you read about HIEs, the one word that always pops up is sustainability. Sustainability.
Yeah. I also would say that it's nice that somebody from the technical side is having a hard time with jargon and nomenclature. It's back at you.
I'm Roberto Hugh Potter from University of Central Florida Criminal Justice and a recovering Fed. I'm going to ask this question as kind of an overarching question for the day. What you all are talking about really seems to me only to apply to the 75 to 100 largest jails in the country. There's another 2,900 or so whose ADPs, average daily populations, are much smaller, whose health care may be provided by contractors, may be provided by the EMT across the street at the fire department, whatever. Is this a conversation, and again, Rikers, as I've pointed out elsewhere, is so unusual in terms of it being a post-arraignment reception center instead of a full-service jail. Same here in DC. Should we really be restricting this conversation to large jails? Or is this something, and I'd ask Dr. May and others who deliver care across multiple jails, how does this conversation actually affect the vast majority numerically of jails that hold about 40% of the people on a daily basis.
Hugh, I'm Steve Rosenberg, for those of you who don't know me. Hugh, I'm going to ask you to defer that question until after the second panel.
Mark?
Ben? Now that we're Mark Stern, I'm from the other Washington. The real Washington. The big Washington. So I'm conflicted, and I know you don't find that as a surprise. On the one hand, my heart, I'm passionate about electronic health records, and I think they're the best thing since sliced bread. And then my evidence-based medicine part of my brain says we don't have a whole lot of evidence to support better outcomes. There is some in the general community, but as you guys have talked about today, our population is different, our structure is different, our processes are different. And I don't know that we can extrapolate the data from the community to what happens in our justice-related population. So I think we're going to be hampered. I don't know that that's going to stop the engine from moving forward, but I think I feel hampered by not being able to say that we actually improve patient safety, public health, and victimization or human rights by the implementation of a health record. And in some ways, again, as we've pointed out today, there may be deleterious effects. There may be things that happen, that undesirable side effects of this new medication, of this new treatment, which is the electronic health record, that may actually make things worse. I mean, we already know, for example, that when a practitioner sits in front of a patient, now there's less eye contact with a patient because they have a screen instead of a piece of paper. Does that have bad effects on the outcomes of health care? So I'm conflicted. If anybody has any medication to help me before the day's out, I'd appreciate it, and that's all I had to say.
So I think that's a good point. I think that rarely in the ramp up and implementation of an EHR do you have a lot of room for cynicism or like frank discussion. I will say I am not and have not ever been like a cheerleader for EHRs. I would consider myself now a qualified proponent of the system, but quite heavily qualified, just from the standpoint of seeing patients. But I do think that, first of all, whatever evidence, if there was a boatload of evidence that EHRs yield better outcomes in the community, I still would be incredibly skeptical about the application of those results or data to the correctional health setting because it's so different. Secondly, I think that what you'll need to do, for those of you who are skeptical and thinking about it, is watch big, medium, small-sized jails as they implement EHRs and talk to them a year or two out. And I think that will be the evidence. There's not going to be a large amount of level 1 evidence about health outcomes in jails, particularly where people are there. People in jail for 30 days or less on average, and so adverse effects of anything that happens in a short-term setting, those adverse effects are going to be felt in the community. So given the fragmentation of information that we've just been talking about, you're never going to find those adverse effects if indeed, as you suppose, EHRs might be a risk, a health risk. The patients will accrue the outcome of that risk in the community, not in jail. So I don't think you're going to be able to look in jails and find good, solid evidence. I think what you're going to need to do is talk to people who deliver health care in jail, talk to patients, talk to community providers, and see if it's improved things. And I think that's disturbing because it's qualitative, and it heightens your sense of internal conflict, I'm going to bet. But it's the best we've got right now.
Yeah, and in that vein, and in picking up some of the discussions, although not the one I'm not supposed to pick up, about smaller jails, picking up what Cynthia was saying too, that the fact that New York is doing this and has such a big system and has so many people and is going to be able to generate so much data, that's a good thing. And it goes back to what you were talking about, David Mancuso in Washington. If you begin to generate some information about what's happening with the population, what kind of health conditions they're dealing with, you begin to be in a position to communicate with policymakers, Medicaid directors, Medicaid health plans, et cetera, about the scope of the problem. And that's a start. That's a very important start. And that's why the work that Mancuso has done in Washington is so valuable for this discussion. He's able to convince or convey to people in decision-making roles, that there are connections between substance abuse, behavioral health, corrections, healthcare expenditures, et cetera, and presto, people start paying attention to it. And the same thing can happen here, which is a value independent of whether or not it can translate and be replicated at the small or medium-sized jail level.
I'm Seema Gajwani from the Public Welfare Foundation again. I'm going to go back to a couple of questions ago when I believe you asked the question about Medicaid billing, and Dr. Summers commented that it remains unclear if it's something that's possible to get Medicaid reimbursement for pretrial in-custody populations. But you also said that it's really interesting that we're starting the dialogue and including correctional populations at this point. And I think that dialogue should lead us to the point of questioning, although this is beyond the purview of this meeting, but questioning if these large pretrial populations need to be in our jails. In some counties across the country, there are 60, 70, 80% pretrial populations in jails, many of whom have low risk for recidivism, many of whom have some of these behavioral health issues that prevent them from being released to the community. And these populations, if they were diverted before they entered the system at the very front end to community-based treatment that would address those underlying issues, would be eligible, obviously.
Thanks. And because we're talking about New York, I just want to talk about a little bit of something that Coaches has been working on this very topic. So many of you may know that states now have a Medicaid option to create this health home benefit, which is a 90-10 federal state benefit to manage the care of individuals who have 2 or more chronic diseases. And New York State is in the process, and actually they have some of their health homes up in some of the boroughs at this point. And we've been thinking a lot about the fact that this is not just folks with hypertension or diabetes, but also folks with substance abuse and behavioral health disorders, and how do they fit into health homes. And so one of the things we've been working on with New York State is putting reincarceration as a metric in the health home, which are all going to be tied together into HIT systems. And so I think part of, Seema, what I'm hearing you say, and I think this is part of the opportunity, is we haven't looked at the availability of Medicaid funding as a way to divert pretrial individuals from custody. And that part of trying to figure out metrics that we can use that are tied to Medicaid funding has to do with how do we align incentives within our system so that we use health information technology to appropriately provide service to individuals in the community who have Medicaid cards in their pocket and who have behavioral health needs within that frame. And I think that is something that we Coaches are starting to pay a lot of attention to. So I appreciate you bringing that to our attention. We have time for one more.
Okay, one more question?
While you're looking for a question, I'll just comment on that too. That I think that part of the opportunity that has been presented with the Medicaid expansion is that you are going to bring attention to the degree to which there isn't enough community-based treatment out there for the populations that you would like to divert, and that's another issue I know, Steve, that you're concerned about and that we're concerned about. So when they have a card, that'll be a reimbursable service, presumably under the card, and that will begin to generate hopefully more community-based treatment, which of course will need HIT to match up with all the other things we've been talking about today.
Well, if there's no further questions, I'd like to thank, once again, Dr. Summers and Dr. Venters for being here. It's greatly appreciated.
Thanks, guys.
Thank you. For those of you who haven't met me yet, I'm Steve Rosenberg. I'm the president of Coaches, and I also want to extend my personal welcome to all of you, and thank you for taking the time to be here. This is a collaborative effort. Coaches is a collaborative effort of convening various partners, and you're all our partners. And I also want to thank Homer and Steve and Ben as well. When we planned this agenda today, we wanted to include speakers and panelists that would shine a light on some of the compelling issues and the challenges electronic health information sharing between jails and the healthcare safety net. I'm honored, therefore, to introduce Judy Murphy to keynote this meeting. A nurse with more than 25 years of health information experience at Aurora Healthcare in Wisconsin, Judy joined the Office of National Health Coordinator for the Health IT as the Deputy National Coordinator for Programs and Policy just 4 months ago in December of 2011. She has a long-standing reputation of patient advocacy and maintaining a patient-centric point of view, and approaches her work with unyielding energy, as well as dedication, passion, and a commitment to the development of healthcare transformation through technology. So I'd like you to please join me in welcoming Judy Murphy.
Great, thank you. Well, good morning. So you probably caught the fact that I've been with the Office of the National Coordinator for 4 months, which makes me a newly diagnosed Fed instead of a recovering Fed. I'm going to start out by framing this a little bit about the patient. I think it's always important when we talk about health information technology to remember why we're doing what we're doing, whether we're talking about electronic health record implementation or whether we're talking about health information exchange. For whatever reason, the work is really hard. You know, it's not like putting barcoding into your grocery store. It's not like automating, you know, the way you pay when you drive on our interstate highways and pay your tolls electronically. It has a lot to do with the people that are providing the care and the people that are receiving the care. And because of that, sometimes we get so focused on the work at hand because it's so hard, we forget why we're doing what we're doing. And so I always like to start out with a patient story. This particular campaign, if you will, that the Office of the National Coordinator has is called Putting the Eye in Health IT. And essentially what that moniker really means is that whether you're a provider, and we've got some providers that are on this campaign as well, or whether you're a patient, in the case of e-patient Dave here, Dave DeBronkart has been a longstanding advocate for health IT and has actually blogs on it and tweets on it and talks throughout the country about the power of health IT. It's again important to remember that we're doing this for a reason. It's the means to the end. It's not an end unto itself. So it isn't about the technology. It's not about the health exchange or the electronic health record. It's really about the change in the way we provide care as a result of that. I've got a real quick personal story. I've had a friend from college, actually, who has had a long-standing bout with breast cancer and finished a course of a clinical trial at Sloan Kettering in New York about 2 weeks ago and wanted to come back to her home, which was in Milwaukee, Wisconsin, which is where I used to live before I moved here. And in order to transfer her records, she had to have them all printed out and carried them in the car with her on her journey, because that's how today, generally speaking, you transfer healthcare information. I call that consumer-mediated exchange, basically meaning, you know, the patient has to take some responsibility for it. And every one of you has that experience, right, where you have gone to one place and you needed to go to a different place and you had to carry the information yourself. As recently as a month ago, I went and was updating, well, I was getting an eye exam and was going to update my contact prescription. And so I went to the same place I've gone to for over 10 years, and they gave me the infamous clipboard with the form. And was that form filled out with the information from my last visit? Oh, no, it was a blank form, and I got to fill it in. Another example, just even within the same organization. And I use those examples because it's not just in the jails that there's a problem here. We have a problem in the country, and it's a problem we're really trying to solve very ambitiously, if you will. So I'm going to give a little bit of background information about exchange in general and then talk just briefly about exchange and why it would be so important in the jails, although sitting here this morning, I think that has already been done, and why this is so important, the stage has already been set. Before I start, how many clinicians, physicians, nurses? Yeah, when I was looking, there's a few of you, and then everybody else is somehow affiliated. I think it looked like there were some lawyers and some folks who work in the criminal justice system. How many people really understand health IT? You know, like if you looked through that glossary of words, you'd know about half of them. Yeah. Okay. Oh, not too bad. There is a plethora of words, and having come to the federal government, I think they've got a corner on acronyms, quite frankly. But, you know, we're dealing with governmental ones, we're dealing with health IT ones, we're dealing with medical ones, and we're dealing with criminal justice ones. And so hopefully I'm going to do a good job of not using any of those words, but if I do, I will try to catch myself and give an example. Okay, so patient care actually is really at stake. And again, I think the stage has really been set quite well for me here. But here's some other kinds of statistics. 1 in 5 discharged Medicare enrollees are readmitted within a month. So they actually end up coming right back and getting readmitted. That's a pretty dismal statistic. Just in general, in our healthcare organizations, we've been looking at that and trying to really impact that. And in fact, there's some payment reforms around the idea that if a patient is readmitted, quite frankly, Medicare is not going to pay for that second admission. And so it's giving some additional incentives for organizations to look at how quickly they're discharging people and how they're equipping them to manage their own care. But it brings up this point of the health exchange again, because the idea here is that we should be transferring them to another type of care. So whether it's home care or maybe rehab or back to the primary care practitioner, it would make a lot of sense that we're passing the information on to those folks that they need to care for that patient so the patient doesn't have to be readmitted. 40 to 50% of inpatient admissions come through an emergency department. So if the emergency department and the hospital are not on the same electronic health record, what happens? That information does not easily get passed. And that, again, is another example of why health exchange is so important. More than 40% of outpatient visits involve a transition to some other venue of care, meaning if you had outpatient surgery or seen in an outpatient setting, that you would then have to be seen somewhere else. There would be some other care situation that you'd be going into. Referring physicians make the purpose of their referral clear only 74% of the time. Point here is that if I'm a referring physician and I refer to a consultant, 26% of the time the consultant doesn't know why I'm referring the patient. And again, health exchange would help that, right? Health exchange could facilitate that because I would incorporate that into the order. I'd say, I want you to see this patient because. Instead, hopefully, we pass that information on to the patient, and the patient can relay that, but we all know how that works. And referring physicians receive feedback from consultants only 55% of the time. So again, we don't have a lot of closed loops. We have a lot of open loops in our healthcare organization. There, quite frankly, is very little health exchange occurring. The cost of exchange today is very high, and the time to develop is often long. However, because of some of the funding that I'm going to talk about in a minute, health exchange is actually poised to grow fairly rapidly in the not too distant future. Again, meaningful use is a concept most people know. I know it got thrown out in the previous presentation. So meaningful use of electronic health records was spawned, the idea was initiated in 2009 through the stimulus bill, where a lot of money was put in this space to try to encourage the adoption of electronic health records. And part of that money was also put in health exchanges. And again, I will talk about that. But that's where the meaningful use concept comes from. It's a staging, if you will, or a maturation of criteria from stage 1 to stage 3. We are currently at stage 1. At stage 1, there was very minimal health exchange required in order to meet the incentives and receive your payments. But at stage 2, we're really pushing the envelope, and I'll talk about that as well. And when I say we, it's a combination of ONC, the Office of the National Coordinator, and CMS, who have banded together, and the proposed criteria for stage 2 is out for public comment right now. And once that public comment comes back and is all digested, the regulation should be out by the end of the summer for stage 2. And again, the intent in the proposed rule is really to push the envelope and get health exchange moving. And I'll talk a bit more about that. So in addition to that, what's happening, of course, in the healthcare environment is that payment that rewards quality and not just quantity is becoming more common. And because of that, the business case for exchange becomes important. So if you think about an accountable care model as an example, in accountable care, you don't have to do everything as an individual provider or as an individual organization that's part of a community, but you need to make sure that it was done in the community. So if a patient has gone off and had their flu immunizations done at public health or at the mall or maybe through the Visiting Nurse Association, you as the primary care provider, you as the acute care facility need to know that that was taken care of. So that's going to be part of your quality initiative too, whether you did it as the organization currently seeing the patient or not. And so this kind of banding together, if you will, of communities to look at outcomes has become a very important reason for exchange. Now, that being the case, there's lots of different experiments going on. It got mentioned in the previous presentation or panel. They talked about sustainability. We're really talking about two different kinds of things when we talk about health exchange. There is health information exchange, what we call the verb, and that's the ability to move information between organizations. And then there's health information exchange as the noun, so that would be the physical entity in the state or the physical entities in some states. There are multiples of exchanges, and it's the noun that requires a sustainability. So they have to have a value proposition or a business model that is going to allow them to be sustainable after the federal money that they're currently receiving through ONC and CMS is no longer available, which is after next year. And so it's extremely important to understand what that business model is going to be. Who's going to pay for exchange? How are we going to document the value so that we would be even willing as a healthcare provider grouping, if you will, be willing to do that? Okay, just some quick statistics, and this is we keep a lot of different information, but this is one I pulled out that I thought would be kind of helpful. On the left-hand side in blue, this is discharge information from primary care providers and the time within which that information is actually received. So you can see less than 48 hours is only 27%, and it just goes up from there. Basically meaning then that if a patient then is seen within the healthcare organization or at a partner of care within the 48 hours, the record is quite frankly not going to be available. And that's part of our problem. If we don't capture it in electronic health record up front, there's nothing to exchange, okay? And so if there's a delay from the time that the patient is discharged or leaves a particular venue of care, and that data is not immediately captured electronically, there's the delay. So let's just say they're seen, and then they leave the primary care practitioner, and he does or she does not have an electronic health record, and in fact is dictating their response. Well, it has to be dictated, then it has to be transcribed, then it has to become available, and therein lies some of these delays. So when we talk about health information exchanges, and again, the panel just prior did a really good job of doing that, you really have to have an electronic health record because you want to capture that information immediately at the point of care or at the point of contact, and then it's the data that's captured electronically that's actually exchanged. Okay, so the two really go hand in hand, and you pretty much can't separate them. The right-hand side of this diagram talks today about how the information is moved around, and you can see the preponderance in the faxing, which does not really count as electronic. There are some people that try to make it. So what is ONC's role? The Office of the National Coordinator is an important player in this because we feel it is our job to make the cost of exchange lower and the value of exchange higher. So the idea here is that we're really working hard through standards and the creation of standards, convening people to use a consensus process to get standards documented and adopted throughout all of our healthcare organizations, and through that process drive the cost down, so that we're not looking at proprietary systems where you have to create point-to-point kind of interfaces, where I have to know exactly what you're sending and I have to hard code in how I'm going to have to accept it. But instead of that, we're actually saying there's a standard, and so I know how you're going to send it to me. And I know then how I will package it and send it back to you. So those standards fall into a couple categories. The first is the vocabulary itself. So you've probably heard words like LOINC. That's the standard for how we describe the lab values. RX norm, that's the standard for how we describe the pharmacy medications. And again, as clinicians or as folks who don't work in the technology, it's not important that you really understand the gory details of these standards, but it is important that you understand that they exist, because otherwise, we quite frankly can't take a medication from system A and move it into system B because we don't know what it is, okay? And so again, unless we would tailor make every single interface in and out of every single system, and when I use the word system, I could mean the vendor system, I could also mean the system of care or the particular venue of care that's actually, that we're currently talking about. So again, we're looking at the cost-value equation, and then the other role of the government is to ensure trust. Okay, so there's a lot of privacy and security issues. There's a lot of issues around provider directories and patient directories, so that we know that when information comes and it says it's about Judy Murphy, that we in fact can trust that this is actually Judy Murphy. So it again is similar to what we had to create in our financial systems not that long ago when we started using them on the internet for buying and keeping track of all of our finances and things. But the standards, decreasing the cost, increasing the value, and maintaining trust are all areas that the Office of the National Coordinator is involved with in order to advance or move the ability to do health information exchange forward. Okay, so what are some of the levers that we're using? I already mentioned we've proposed some pretty stepping it up kind of criteria at stage 2, where we're sort of feeling there's an inevitability about electronic health records, and I say that very cautiously. I have lived much of my life, although I'm a nurse by original background, I did move into IT 25 years ago and have been installing some kind of an application ever since. In the 15 hospitals that Aurora has, we had so much fun doing it the first time that we actually decided to switch vendors. So I installed, I think it was 350 individual private practitioners and the 15 hospitals. And then before I left, I had converted 3 of those hospitals to the new vendor. Computerized physician order entry was accomplished as well. And these are, painful things. Dr. Ventures, I think, addressed that earlier about this is a workflow change. If you're really going to take an electronic health record and use it appropriately, it's not just about taking what you had on paper and putting it in the computer. It actually is about using the computer to its max capacity. And so, these are, again, painful implementations. But once you get past that, you start to see the value of having electronic lab results at your fingertips and being able to take lab results and, trend them over time or trend them against blood pressures if you're looking at the impact of a vasopressor, for example. So those are some of the things that you start to realize are huge values. Our standards interoperability blocks are, I'll say, in place, but that's a qualified in place. It's not like every standard that we're ever going to need is done, but those basic building blocks are in place. In your glossary, there are a couple of terms that I would draw your attention to, and the first one is direct. Direct is one of the standards that we have proliferated for the packaging up of the vocabulary words so that they can actually be transported and unpackaged by somebody else. Oftentimes, what we communicate in that package is something called a CCD, or continuity of care record. It basically is kind of like taking information and putting it all together in an email, but in the email, there's sort of a wrapper around the email that talks about the information that's inside of it. So that when you receive this quote-unquote email in the receiving electronic health record, that sort of wrapper or packaging can actually decompose the email back into the actual data that was in it. So that when you get a CCD, instead of it being like a blob of data, you can actually take it and know there's lab data in there, and that lab data can be imported into your electronic health record and would actually appear with your other lab data on a flow sheet. So that's why things like these standards are so important. Otherwise, you could look at it and it'd be a blob of data, which of course is better than having to fill out the clipboard from scratch, but it's not really where we want to be. We want to be able to actually take that structured data and import it, if you will, into an electronic health record. So direct is one of the standards that we're using. The other one is the Nationwide Health Information Network, or NWHIN. That's a much more robust standard in terms of exchange. So instead of being an email, and the value proposition for health exchange using this direct process is, I'm a doc, I'm referring to you, I know you're going to see the patient, I package the stuff up and I send it to you because I know you're going to need it. Okay, that's the common use case in direct. It's where I send it. In the Nationwide Health Information Network, it's really a different kind of standard. It's what we call query-based, so that I would actually go out to an exchange and I would say, do you have any information on Judy Murphy? And if you do, send it back to me. You can imagine the level of standard requires quite a step up from this sort of packaged email with the wrapper, okay? But those are really the two kinds of building blocks that we're looking at using right now. The Nationwide Health Information Exchange governance will increase trust and reduces the need for the one-to-one negotiations. So what we're talking about there is in that query model where I go out and I say, do you have anything? We do have to have governance of the way that we do that, okay? And the two bullets that I put there were digital certificates and data use agreements. They're just really words around the idea of how we would establish trust so that when I'm asking and then grabbing something that you have put out there, that I trust that it's coming from a source with good, valid information, and that we have prearranged our trust, if you will, in a data use agreement using digital certificates. So I think I'll leave it at that for now. But as you can sort of imagine, this is not something that we could take lightly because we're talking about protected health information, okay? And there's a lot of privacy and security issues around patients and how they want their data shared as well. And that's another scenario where the government is spending a fair amount of time, is really thinking this through. It is the number one concern for patients that, so for example, if I send information that I know about a patient to you, and then you refer the patient to yet a third party, do you have the right to send the information to the third party that I sent to you? Or can you only send the information that you have now collected? You can see I'm giving you a very simple example of the issue, but you could imagine that kind of compounds itself when patients are moving in and out. I used to think that there's some closed networks where health exchange isn't a problem. I remember thinking several years ago that the Veterans Administration, my father was a vet, and he was seen throughout the VA in the last 10 years of his life, and I thought, this is where it's at. The VA, they have everything. They've got this all figured out because they give you the drugs, so they know what medications you're on and everything. Well, as it turns out, statistically, 40% of veterans are seen at a healthcare organization outside of the Veterans Administration. And of course that varies around the country, but it has to do with the whether there is a VA in your particular vicinity. It also has to do with, in your vicinity, there might be a VA, but they don't do mammograms. And so they outsource mammograms to another organization that does them on your behalf. Well, you can imagine those results, again, have to get back into the record that's used there. So this is a problem, literally, for everybody. It's not just certain kinds of organizations. Okay. So the state HIE program itself, I mentioned, was inaugurated, if you will, through the stimulus bill or the HITECH Act. And that was in February of 2009, and it authorized the establishment of the State Health Information Exchange Cooperative Agreement Program. Now, that was one of multiple programs that were initiated at that time. We talked briefly about meaningful use. Some of the other words that are in your glossary that relate to this, so there were SHARP programs, which were looking at some of the sticky wicket issues, if you will, in the use of health information technology. Beacon communities, 17 beacon communities were inaugurated to look at how do people band together in a community and start to do group reporting, and how do you prove the linkage between the use of health information technology and the outcomes that can be achieved. And the beacons have been in existence now, again, for about 2 years, and it's really quite exciting to start look at some of the movement that they're seeing in some of the chronic conditions like cardiovascular disease and diabetes. And again, this is when the whole community bands together. So these are kind of precursors, if you will, to some of our ACO pioneers and those kinds of things. However, back to the state HIE program, there was a total of $564 million awarded to 56 states. So you can do that math fairly simply. About $10 million was given to every state. And there was some variety on that based on the size of the state, based on the proliferation or the number of primary care providers, the number of hospitals, et cetera. In order to get the money, the state, in addition to standing up, if you will, their state-designated entity for health exchange, they also had to designate a health information technology, or HIT, coordinator for the state. Those HIT coordinators sometimes report within public health, sometimes report within government, for example, directly to the governor in some states. And they're working, as you can imagine, some very well, and actually leading the state quite effectively, and in other cases, they're really not doing all that much, and we see everything and anything in between. What we have seen is through the HIT coordinator, in many cases, sort of a pulling together of some of the programs. So within a particular region, and one that comes to mind is Ohio, Texas, New Orleans, where they're actually taking the beacon communities, the state-designated HIE communities, and the regional extension centers, which was another program that we stood up to help the small providers, and really looking at economies of scale and how they can be helping each other. So again, the money that came through the stimulus bill, although the majority of it was toward this EHR incentive payments and getting organizations to adopt electronic health records, there were all these other programs that are feeding into that as well. And so the health exchanges, though very important, one of the ways we're going to actually get better adoption and use of those exchanges, quite frankly, is to band them together with their communities and the organizations in their state to make sure that these are being used effectively. That being said, in many states, there are multiple health exchanges. In New York City alone, for example, there are 4 health exchanges. Now, I understand that they are banding together and looking at some economies of scale, but the idea, as I talked about earlier, this sustainability idea, is that the business models vary from region to region, state to state, what the organizations are looking for from a health exchange vary. And so I think we're going to see some of the state-designated entities that we have funded through the stimulus bill and the HITECH Act succeed, and we'll see some probably not succeed. We will also see some that were not funded succeed, and some of those fall by the wayside. So this is a marketplace issue, if you will, and that's why the sustainability becomes so important. Okay, so basically what we're trying to do through the state HIE program is make sure that we support the providers in that state or in that area in achieving their health information exchange meaningful use goals, and making sure that we're promoting innovative approaches to the secure exchange of information. So again, really feeding into the marketplace. And the goal is to make a nationwide health information exchange actually a reality. So I've got some goals on the next slide here. The program goals are to foster exchange networks, to monitor the exchange and to fill the gaps, as well as ensure exchange across networks. Now, what are we actually focusing on in the proposed stage? Oops, I think I pushed the wrong button. There we go. In the proposed rule is to ensure that 3 areas, actually, e-prescribing. We think this is one of the most important ones, and actually a fair amount of progress have been made in e-prescribing, but here we're talking about that all prescriptions would actually be done electronically, and they would be not just completed and signed by the physician electronically, but they would be transmitted electronically to the pharmacy, accepted by the pharmacy, and then filled in the software. So no human intervention. No, I send it to the pharmacy, it prints out, somebody takes the printout, turns around and enters it into the pharmacy system, okay? So really pushing on making sure that there's a closed loop with e-prescribing. Structured lab results. Since the standards are pretty good in this area, we think this is the second area that we should be promoting exchange and really pushing the envelope. This is one I think that bodes pretty well when we think about the jails in terms of lab data that had been collected in the community and the ability to pull that into the electronic health record, that hopefully the electronic health record that's used within the criminal justice system. And then last, the actual sharing of patient care summaries. And the idea here is that we don't have to do consumer-mediated exchange, you know, with the paper records, but in fact that at the end of an encounter or at the end of a time transition, during a transition of care, that we'd be able to send the information from one place to another. So again, the idea is to really reduce the costs to protect Medicaid and the fragile safety net, and we talked actually about that in both of the previous presentations, the panel, how important it is to know what was already done so we don't duplicate information. And I don't even have to go through this one because I think this was all said before, how important it really is for jails, along with all other venues of care, to have this capability. And again, I'll remind you that although the title of this workshop is about health information exchange, and we're focusing on health information exchange, that you really can't do exchange without having an electronic health record. So this is really about, you have to install the electronic health record, and when you do that, you will be enabling exchange at the same time. But then, of course, you do have to physically hook up to the exchanges in your communities to be able to get that information. I would say probably the statistics are that the penetration of electronic health records in most healthcare organizations is decent. It's been going up rampantly over the last couple of years. There's some laggards in that, and I think the laggards in that are the jails, and I think also some of our smaller practice primary care providers. If you're a provider that works in a larger organization or affiliated with the hospital, you've probably got some bench strength, if you will, to be able to implement an electronic health record, but there are many, many, many areas of our country, in rural in particular, where we still see not a good penetration of electronic health records. And again, the statistics in your space also sound pretty dismal. And last but not least, the other area that we talk about a lot, so rural jails, the third would be long-term care. We're just really starting to see rehab facilities and long-term care begin to install electronic health records. So these are 3 areas that I think we healthcare government really do need to be focusing on. And then just some really quick ways, and you've got my handouts, that you can stay connected with what's going on at the Office of the National Coordinator. We blog, we tweet, we've got a couple of really good websites. Our whole Putting the Eye in Health IT campaign is out there with some videos and with some case examples, and we actually have patients and providers that do blogs as well and talk about their experiences. So with that, I will close. This is something that we say within the ONC. We have to keep our feet on the ground, but we have to keep our eye on the prize. And basically what that means is there's a lot of down and dirty, nitty-gritty work that's still got to get done. We have to keep our feet on the ground and get that work done. But we can't forget why we're doing what we're doing, and we can't forget that we have to keep looking at the next thing that we need to be focusing on after we get done what we need to get done today. So that constant balance between get the nitty-gritty work done, but remember you're on a journey towards something greater. And certainly the electronic health record and health information exchange is a journey and not a destination. And with that, I'll close. Thank you.
I want to personally thank Judy. I know she had a busy day to take the time to come, and I think that your coming speaks to the commitment of the Office of the National Coordinator to hook those of us involved in criminal justice into the Data Hub. That's what this conference is about, and we really appreciate your personal commitment, Dr. Mastari's personal commitment, and the commitment of the office. And for those of you who are unfamiliar with this space, that's partly why we're here, is to familiarize yourself, and you did a wonderful job of doing that. So thanks again, Judy. We're going to take a break now. I'm a time punctuality freak, so we'll be starting promptly at 11:15. We have a packed agenda, and we want to get to everyone's questions and concerns. So 11:15 sharp. Thank you very much.
All right, so we'll start now with the second panel. I'd just like to say that before we start this panel, I kind of feel like I'm with Captain Kirk on the spaceship, because we're taking folks where man has never been before, okay? So just hang on. The day-to-day challenge of providing health care in jails with difficult patients, rapid cycling of inmates in and out of the jails, lost medical records, all of those kinds of things have resulted in proprietary healthcare industries seeking to develop electronic systems that try to simplify the workload and assure patient safety and track information. Not a small task. Today we'll hear from two chief medical officers of proprietary correctional healthcare companies about their experiences with these systems. Dr. Carl Keldy is with Corizon, and Dr. Raymond Herr is with Correctional Healthcare Companies. Correctional Healthcare Companies started its work with a preferred relationship using a system called Core EMR. Corizon, the largest proprietary correctional healthcare company in the United States, began building its own system known as Catalyst under its predecessor, Prison Health Services. Both of these companies have recently decided to adopt an electronic system to track CPT and ICD-9s, the codes for diagnosis and for billing. We at Coaches believe that this shift is due to health reform and the need to create connectivity between jails and local healthcare systems. Coaches, a couple weeks ago, we sent out some papers to all of you, one of which described some of Dr. Herr and Dr. Keldy's work and experiences, as well as some experiences of Dr. Campolo from Ohio, who unfortunately couldn't be with us today, but we'll have some indication of some comments about his work. But they have, in the paper, it talked about developing electronic health data systems. And in this session, what we'd like to do is kind of flush out some of that information then engage you in some discussions about it. Before we do that, though, I'd like to talk a little bit about the panelists. Dr. Raymond Hurd joined correctional healthcare companies in 2007. As the Chief Medical Officer, he has direct clinical oversight for all provider services within CHC and Health Professionals Limited, as well as clinical oversight of utilization management for CHC. Dr. Hurd has been involved in correctional health care for 2 decades, having served as medical director in many county jails in Colorado and most recently in Jefferson County Detention Facility and Broomfield, Connecticut Jail. In his role as Chief Medical Officer and Senior Vice President at Horizon, Dr. Keldy is responsible for the establishment and oversight of company-wide medical and clinical service policies and procedures, credentialing, infection control, continuous quality improvement, and utilization management for healthcare service delivery to more than 200,000 offenders. Prior to joining the company in 2000, he practiced emergency medicine for almost 20 years and has extensive clinical and administrative experience. And, of course, you all are familiar with the esteemed Rosenberg. So, for Dr. Hurd and Dr. Keldy, as jails, are jails special environments where, so much so that the HIT systems require different information from that in the community? And if you would you tell us about your experiences with regard to HIT in jails and some of the challenges and opportunities you see going forward? Either of you, take your pick.
Yeah, I don't mind starting. We began with the EHR through Core EMR, and it was a system that worked fairly well for us. We had it at several of our larger jails, and it was a system that helped us deliver care to inmates, and it was not a system that we used to connect with our corporate office. And as time went on, we realized to better serve our clients that we needed a system that would allow us to do the process, and we developed Vision. And Vision allows us to have sites, and pretty much all our sites are connected to Vision as far as the process. They can send us information, requests for referrals, as well as requests for medications. And that is done pretty seamlessly, and helped us, at least as a company, better serve our clients. We have two clients. One is the counties that we're contracted with, and the prisons that we're contracted with, but also we consider the inmates our clients as well. So to better serve our clients, both as good patient care, we also wanted the system which Vision gives us to allow us to pretty seamlessly deal with referrals as they come in. It's almost on a real-time basis that we've got requests coming in. They come into the office, they immediately come into the department, and we can turn them around typically with the urgent request, turn around within 24 hours. And medications go, if they're part of our regular formulary, they go directly to our pharmacy electronically. And if they're non-preferred, they come into our corporate office, our department. They can get reviewed, again, on a real-time basis. So within an hour or two, they're turned around, approved, and then sent over to our pharmacy. So Vision has been helpful to, we think, give good patient care from the standpoint of having sort of real-time referral review as well as medication review.
Okay. Dr. Kelly?
Thank you. I've been behind bars probably at 200 facilities around the country. My background in emergency medicine really was jail medicine, because that was my first experience with correctional medicine, is when the police officer would bring somebody in handcuffed and beat up and want to know how quickly he can get out of my emergency room. And the real critical point there, they wanted to know whether I was going to admit him to the hospital or not. because they weren't going to arrest them if I was going to admit them to the hospital, so they wouldn't have to pay for them.
Right.
One of the adages in jail medicine is when you've seen one jail, you've seen one jail. And it's and it is hard to standardize care, to reduce variability, to keep patients out of harm's way with paper records that get modified based on heuristic medicine and based on the disease of the day. And we really, our vision was that health information technology applications would reduce variability, would help prompt risk stratification, because what I want to know, who are the sick patients? Who's going to get into trouble? Who is potentially suicidal? Who potentially has active tuberculosis? And that's where I see information technology really assisting in jail specifically.
Okay, could you talk a little bit about some of the challenges that you encountered and what you think might be some anticipated challenges going forward?
How long we got?
Okay, all right.
No. One of the biggest challenges is, I talked about standardization, but we have very fine policies in place, procedures in place, and then the rubber meets the road, and you've got to try to work with what you've got. Many of these jails they were set up as jails, not as places to provide care and screen for care. And you have the ubiquitous workarounds. Yep, I know that's what the policy says, but to make it work, and in order for us to move people out of the sally port where you got 30 people clamoring, we got to do it this way. And one of our biggest challenges is putting information technology, and Homer said it very well, it really puts a bright light on processes and on policies and procedures and the workaround and the behavior drift that exists in the most challenging healthcare environment I think there is in this country. I thought emergency medicine was hard. Jail medicine is hard on steroids.
Okay, Dr. Herr?
Yeah, I think, the challenges, at least as I try to think about corrections and I try to think about IT, dollars are, the counties that we contract with are all pinched for dollars. So, the smaller jails, the thought of bringing in computer systems for, an electronic medical record is really so far down the road for them. They have other sort of issues as far as where they're putting their dollars. So dollars are probably, at least within the county jail system, probably one of the challenges to bringing in a system. The health communication within a jail is difficult because as an inmate comes in, they get their care from emergency departments primarily. They really don't have primary care doctors.
Right.
And so, number one, they're coming in and they're saying, yeah, I was seen last week. Well, where were you seen? And they can't quite remember because they've been to so many emergency rooms. So what we do when they get into booking is we begin immediately identifying nearby hospitals and saying, hey, do you have any records on this particular inmate? And the same with pharmacies. They say, oh yeah, I get a lot of medicines, and well, where do you get them? Well, I'm not sure. I think I go to Walgreens, and I think I get these from the grocery store or pharmacy. So the difficulty is, number one, their ability to tell you where they get their medications and where they get their care, and then they have aliases. There's you're trying to get information about medications under different names. So there's certainly challenges with that particular group because they don't get their care from the family doc primarily. It's emergency rooms, and it's different emergency rooms. They come from out of state, so it's a challenge as they come into a facility to get the right information.
Okay, so Dr. Kelder, you mentioned the workarounds. Could you talk about some of the potential impacts of those workarounds as we go forward?
Workarounds exist whether you're on paper or an electronic medical record. The electronic medical record doesn't make you ask the questions a certain way and doesn't solve everything. The the typical workaround is, you know, you have somebody that presents and they reportedly have diabetes. Well, the glucometer got broken on the last shift, so now I'm not going to enter a blood sugar record because I would have to get the glucometer from another place within the jail. And so you put an NA or something. In an electronic medical record, you can actually have a forcing function that requires you to enter that a number before you move to the next question. The electronic medical record also helps you in that if you ask certain seminal questions, it prompts you to take an action. You can no longer write down 3 suicide risk factors on a piece of paper and just kind of go, well, yeah, I guess I remember that that's somebody that should be put on watch. With the electronic medical record, it can actually tabulate that and give you a score, and at the end of the record, print out a report to security that this is somebody that needs to go on suicide watch. So that's a couple of examples that an EHR can help with some of the workarounds that happen in this environment, in this workflow-centric process.
Okay. So Steve, can you give us some feedback about Dr. Campolo's story in Ohio?
Sure. I guess it goes back to sort of Hugh's question before. So Dr. Campolo is a family doc in a small town in Ohio who was an early adopter of an EMR, and he got the county to buy the same EMR that he had in his office and put it in the jail with the idea that he could take connectivity back and forth because he was seeing the same guys. Well, the problem is that EMR systems migrate and upgrade, and there's generally a fee for the migration and upgrade. So he kept paying for the migration and upgrade within his practice, but the county wasn't willing to pay for the migration and upgrade in the jail. So what happened is what started off as a totally connected system, small jail, Hugh, going back to your question, relatively inexpensive to do, another license for what he had going on in his practice, soon became this. And that's where we stand today. And I think that speaks to part of the challenges in general. In your paper, there's an article that was done by the National Association of Counties that sort of speaks to this question. You know, the health care is the tenant and the jail and the county are the landlords. And so the landlord gets to decide what level of capital improvement that they're making in their premises. And in that case, they decided to not upgrade, which sort of broke the connectivity, which I think speaks to some of the questions on the challenges within the small rural jails, which is why, Hugh, I asked you to save your question. Mike?
Okay, so Dr. Herr and Dr. Kelde, many of us here today know that one of the ways jails are unique is the scope of practice creep. And that due to the intensity and time sensitivity of the booking and intake process, some of the healthcare services are provided by folks that are less licensed or skilled or trained or whatever. What do you see as some of the potential implications of implementing HIT in jails with those considerations?
Yeah, we have with 75 jails in over 20 states, we see a broad range of how things are done in security's house, and we rely on our correctional officers to do a level of triage. They do triage in the field when they're arresting somebody. They do a level of triage, and we have facilities where the correctional officers are very good at asking a number of seminal questions so that they can expedite a referral to a clinical staff member. And we see times when they get a little over their scope of service or make a determination, they'll respond affirmatively to a question they were supposed to refer, and they're busy or they're distracted and they don't. So I think health information technology actually helps you to quantify when that happens and to help prevent it from happening, because when you answer a specific question that you've been hospitalized in the last 48 hours, you don't get to just answer that question and forget about a response to it. That automatically prompts a triaged response from a clinician doing the intake process.
Okay.
Yeah, and I agree, and I think with regards to like a booking process, if you have an electronic medical record in place, and you have that ability for a provider to see if it's web-based, you know, a booking officer or a triage nurse or EMT can communicate with a provider who's not at the site. If it's web-based, you can pull up information. And again, if you've got a system that communicates with other systems within the community, it would I think, help this whole idea of this creep as far as the someone doing work that is, you know, kind of outside of their realm. I think it would lessen that. So I think the connectivity piece would be helpful.
Can I delve into that just for a minute and talk about what I think is the elephant under the table? We all know, because of the chaotic environment of jails, we have COs doing screenings that are really assessments that should be done by a registered nurse. We have mid-level practitioners providing care that in a community setting subspecialists would be normally providing. We have correctional officers dispensing medication, which they may not be able to under the scope of practice within their state. That as long as jails have remained an island, nobody's noticed, okay? And nobody's noticed and nobody's cared. I think one of the challenges of health information technology is that it starts shining a light on some of those questions. And if you think about that, particularly going back to Dr. Summers' comments this morning, early this morning, about health reform and Medicaid, where in order to participate in a health plans panel, I probably have to be board certified. You guys both know what percentage of docs in your facilities are board certified. It's not more than half. Okay. I'm going to have a transparency of some of these functions that are scope of practice creep. I have a general shortage of health personnel in the community. I don't have enough board certified primary care docs to go around in the community, let alone those that want to work in a jail. I don't have enough RNs in the community, let alone those that want to work in the jail. Doesn't health information create an almost insurmountable issue around transparency and building that information bridge in terms of the secrets that we've been keeping about how we manage our business in a chaotic environment?
Can you repeat that question? I actually think health information technology gives us an opportunity. One of our challenges in correctional facilities around the country is a staffing challenge. But guess what? When you have good information technology, good connectivity, good broadband, then what do you have, Homer? You have telemedicine. You're no longer relying on the only person that might come from that community, the only doc in the community. You now can have a face-to-face encounter with a wound care nurse, not just this nurse in the community, with a board-certified physician who can then see patients in 10 different jails in an 8-hour day. So I really think information technology, while it will shine a bright light, and I think that's accurate, the bright light may not be a freight train about to run you down, but it may be the end of the tunnel where we can actually provide consistent care with qualified practitioners who care. So I see it as opening opportunities.
Half jar, jar's half full.
Three quarters.
Right?
Yes.
Right.
Yes.
Yeah, no, I think, I like the positive spin on it that Dr. Kelly put it, because I do think there's, with IT, I think, and it was kind of brought up this morning as well, that there's clearly times where IT is going to show us where we've got problems, and it's going to generate probably some headaches for us that are trying to put the right people in jails as far as the staff, because you can't get away with doing some of the things that have been done in the past. And again, the spin with telemedicine, I think it is correct that you do have that ability to, if it's a small facility that doesn't have the ability to bring a doctor in more than a few hours a week, that with telemedicine you can have a provider take care of an inmate from offsite, which if costs are a big part of how counties look at what they can do, that certainly should help.
Okay.
The other spin, with an electronic medical record, you can actually create a clinical dashboard of your highest risk patients, and that was really one of the more successful features of Catalyst. And I couldn't do anything with ubiquitous information. Me knowing every pregnant female in our scope of services didn't allow me to really address who might be at the higher risk. So we found from an intake process a 15-year-old in a juvenile facility, and our OBGYN specialist had a telephone conference, a safety huddle with the site within 24 hours of her coming to the facility. And we do the same thing with oncology, with endocrinology, and this dashboard really helps with risk stratification and identifying patients where we can really make a difference and who really are at risk.
So Steve, as we enter the world of Medicaid and the exchange, can you talk a little bit about some of the challenges, staffing challenges that we might face?
Well, I think part of it we just talked about, which is this whole issue on participation in health plan. Let me go over a couple of them. I think they're not just staffing. So we all had the pleasure of being hosted by Dr. Venters at Rikers a couple of months ago, and they have a very slow freight train. Between when that young man is arrested and when that young man is actually seen by a practitioner, we're talking in some cases 48 to 72 hours on that assembly line before it goes through. If I have a diabetic young man in the course of that, they're going to be making several ED visits. That's not going to work within a managed care paradigm. I'm going to have to do something about fixing that freight train. I'm going to have to do something about qualified personnel. You know, I love telling this story, and you guys all know it, about a young person who came in who might be rather inebriated at the point of arrest, and a correctional officer does the screen and asks the guy if he's an epileptic or had epileptic. He goes, oh, no, never. And 16 hours later, he's in general pop and he has a grand mal, and we take him over to the ED, and it's now in my brave new world of health information transparency, and the admitting nurse in the ED gets to see the screen that the correctional officer did, which she decides is an assessment, and next thing you know, she's on the phone with the Board of Nursing. So I think that there are some very significant issues that we're going to have to pay attention to within that paradigm in terms of expectations. And I said, because we have this general labor shortage, I think telemedicine is a great solution. I think in psychiatry, it's been shown to be really effective, and I think most of you guys are using it in psychiatry at this point. I think the question is, how do we manage that at the primary care level? How do we figure that out? And what level of credentialing will health plans make to the folks who are going to be on the other end of that video screen? So I think there's a whole bunch of challenges, and I think we don't have a lot of time to start figuring them out, quite frankly.
Yeah, 2014 is right upon us.
Right.
So, Dr. Kelly, behavioral health has been removed from meaningful use criteria. And even though we know that funding for behavioral health services and communities is a key to savings in the criminal justice and in our healthcare systems, it's difficult to keep up with the evolving complexities in these HIT and all of its forms and the relationships with the criminal justice system and the social safety net. So the proprietary correctional healthcare industry is trying to lead the way in jails and prisons around coordinated policy, but there is no coordinated policy. So where do you think that leads us as you try to continue in this effort?
Yeah, not a simple question. We've siloed mental health care in this country since the 1700s, when they had the first insane asylum in Virginia. And we've siloed them in insane asylums, and now we silo them in jails, and we silo them in prisons. And even in the private world, if you talk about 74% of there being communication between primary care specialists or the primary care clinicians and specialists, the exchange of information between psychiatry and primary care is abysmal. One of our biggest challenges, even in corrections, is to not silo mental health care, is to integrate mental health and medical care. There's a significant trend in the community to doing that, is to taking medical and mental health services and integrating. One of the most promising, I think, steps that are being taken are the patient-centered medical homes. NCQA has certified over 3,000 patient-centered medical homes around the country, and more of the patient-centered medical homes are bringing mental health workers into their office. So you're not making an appointment for them to go see somebody, you're seeing them in their facility. And when we're really doing our job well, that's how we function in a jail or a prison. As a patient-centered medical home, we refer, we know when they've been seen, you get the information back, and I think that's something that we're going to continue to address. It's going to continue to be a challenge, and one of the hardest challenges that we face is what happens when somebody now gets that mental health diagnosis. Now they've been labeled as a psych patient. And once they're a psych patient, that's what I've seen on too many people's, their first reflex. Oh, it's a psych patient that's having an asthma attack. You know that psych patient with diabetes. The psych kind of primes everybody, and the next thing you know, well, I wonder if it's a psych, if it's really a psych
really
complaint.
An asthma attack?
Yeah, and we've seen bad outcomes from the labeling of that. So I think that's another barrier that we have to break down. And I'm not sure how information technology is going to assist us with that, Michael.
Hey, Dr. Hurd, you got any feedback on that?
Yeah, I don't know that I have anything to add to that.
Okay, all right. So we'll field questions. If anybody has any questions for any of the panelists. We got a question here. Well, hold up for the mic, please.
And please identify yourselves.
Thank you. Steve Spencer, correctional physician. I'm just curious, looking beyond the geographic boundaries of the United States, are there any other countries that are making faster progress or slower progress than the United States in the area of information technology exchange, such as Canada, Western Europe, the UK? And what are the social, political challenges that we may have to face as a free enterprise system that other more controlled societies don't?
Well, I can take a quick stab at that. I think that, you know, any society or country that has a single payer is going to have a system that makes more sense as far as that information exchange. You know, here in the U.S., as we know, how many payers are there? It's endless, and so the problems until we get to a single payer system, I think, will continue to be very tough compared to some countries that have a single payer.
The flip side of that, of course, is the experiment in the United Kingdom, which does have a single payer, which put billions of dollars into trying to create a top-down EMR system that totally flopped. And so it's a very interesting question that you're asking, Steve.
And, boy, this is the fun part of being here. I can call somebody out. Dr. May be able to actually, actually opine on this, because he's been very instrumental in the International Prison Association. We were at a joint meeting a couple of years ago and got to see, if you want to talk about disparities in care in some of the underdeveloped countries versus one of the most incredible healthcare systems and reentry programs that took place in Singapore. John?
Thank you. Singapore actually has a very elaborate electronic health record, which does connect to their national health system. So that would be a good example to shine. But there's a variety all across the world, and I don't know that anyone has the market on the right way to approach it. Interesting, Panama has a very elaborate telemedicine program. All of their prisons are connected through their Ministry of Health, and the Ministry of Health is the provider of care. And Mexico is also moving that way through their federal prison system. So those are some examples. But I don't know that anyone in the world that I'm aware of has the right answer. Everyone's moving in this direction now.
Can I ask a quick follow-up?
You mentioned Mexico's federal prison system. What's going on in the U.S. federal prison system?
The Federal Bureau of Prisons actually have all of their federal penitentiaries are actually connected with a single web-based electronic medical record, and that's been deployed, I think, 8 years, Brian?
Yeah.
7 or 8 years in the Federal Bureau of Prison, and 6 years.
6.
Yep.
Century. Okay, any other questions? Okay, no questions.
No, you got questions.
All right, here we go.
2 more.
You got 2 more.
Couple more.
Hi, I'm Kamala Malik-Kane with the Urban Institute, and I had a question that it sounds like one of the benefits of EHRs that you're talking about a lot is that there are, various, I guess, algorithms that are embedded within it to kind of bring things to providers' attention. And I was wondering about the flip side, and a couple of things, I guess, sort of provider acceptance of kind of being guided in certain directions to evaluate certain things and to take certain things into consideration. And if there are places or examples where the guidance of the electronic system in terms of what to ask and what to screen for has failed.
Adoption of electronic medical records are a challenge that are not going to go away. And we've seen both ends of the spectrum. One of our dashboard characteristics that we have is we want to know if you have asthma, have you ever been intubated? Have you ever been put on a respirator? That's a risk stratification. That's someone that's high risk. That's someone you don't need to be waiting 30 days to see them in chronic care. And so when we first started our dashboard, we found hundreds of patients with asthma who've been intubated. Well, guess what? We asked the question wrong. Because when you ask somebody that's right off the streets that may be inebriated, have you ever been intubated? What does that mean? I'm feeling a little that way right now. So we changed the question. Have you ever been in a hospital where it was required that they put a tube down your throat? So, and I don't know the exact question, but the rate of intubation dropped precipitously. And many of our practitioners, our nurses, just feel so much more comfortable with the triggers and the alerts and the buffers that are built in. Others feel like this is a pain in that I have to now put a mask on somebody because they admitted to hemoptysis, coughing up blood. That's extremely high risk, and it does require activity that before they could just click a button and go on. So that's a very good question, by the way.
Yeah, and Cam, I want to try and take that from another angle, and we'll talk a little bit about this later on this afternoon, which is that part of what we perceive at Coaches that the health information technology allows is what we would call a routinization of care, that you basically get to create some standards and standards of practices which promote patient safety. I think, again, because typically jails have been unseen and the providers have been unseen, that those kinds of prompts from where we sit are welcome at this point in the evolution of jail healthcare. I think it was another question on the, yeah.
Yeah, it was over here. Devin McGraw, I'm with the Center for Democracy and Technology. This is my first exposure to this issue from the incarcerated population side, but I've done a lot of work with Judy Murphy and others at the Office of the National Coordinator on encouraging the adoption of standardized health IT and health information exchange. And I'm really trying to pay attention to some of the conversation that's gone on today about the extent to which the records in the jail system need to be somewhat unique to respond to the needs of the jail system, and yet the activity that's going on outside of that incarcerated population is all sort of being driven towards the adoption of certain standardized tools like the CCD, use of standardized vocabularies like the lab vocabulary and the e-prescribing vocabulary. I'd love to hear more about, especially since you all are the industry providers that cover a lot of jail healthcare systems, to what extent are you trying to work on having there be some interoperability between the tools that you're creating and using in a prison-based system, a jail-based system, versus being, again, if the desire is to be able to exchange information with the outside, with the world outside of the incarcerated population, to what extent are those efforts being merged together in some ways? I don't think we're doing a very good job of it at all on our end. On the other hand, I'd be very eager to hear how those efforts are going from your end.
Yeah. I think health information exchange is a pretty lofty goal when the health information that we're gathering has such huge variability in it. And if we're going to exchange misinformation, what are we exchanging? And heretofore, I think everybody knows that the background, if not the backbone of electronic medical records, have been E&M codes, so that you can bill, so that you can document something, that you get a first-pass reimbursement. And there really hasn't been much clinical decision support. The clinical decision support is an icon. And you go click on the icon and it says, oh yeah, it's time for a mammogram. True clinical decision support is taking disparate data within an electronic medical record, and while the clinician is there, be able to feed him actionable information. Yes, this patient with diabetes is on metformin and his creatinine is now 1.7. Warning, Will Robinson. To be able to really do this at the point of care and have good clinical decision support. So I think the whole industry of electronic medical records is in its infancy. It's really has been to the digitalization of paper stuff. And I think it's going to be a real challenge to put good evidence-based medicine behind clinical decision support, resulting in actionable information where when people look at the Affordable Care Act, they now just call it the Affordable Care Act. It's actually the Patient Protection and Affordable Care Act. The patient protection is where we need to go with electronic medical records so that we can prevent errors of omission and errors of commission in healthcare practices. And this is the community, the emergency rooms, jails, and prisons all over the country.
And then, Carl, before you wade into that, I want to just add to that. And then you have a population in jail of generally young people that have beat up their bodies with drugs and alcohol, who have no primary care, who have co-occurring behavioral health disorders, for which I don't even think we've thought through what are the clinical decision tools that are needed in that environment. I think the other part of your question, Devin, is that it's not just that the environment is chaotic, it's that the patients that you're seeing are not just the unseen provider, they're the unseen patients, okay? These are patients who are getting their care in the ED with a lot of complexity. And I know Dr. Barton used to tell stories about all the pathology that he would find in young men when he worked as a jail doc. I think both of you guys have found weird pathology in young men in working as jail docs. So I think the decision support threshold in a jail environment is much higher than it is in a community environment. And I think, Carl, as you said, we haven't worked it out in a community environment. Ray, what would you say on this?
Yeah, well, to go to your question, you know, it's a key, you know, it's a goal that, you know, we strive for. With right now, we're trying to get a system in place so we can connect amongst ourselves rather than into the community. We know the importance of connecting to the community because it's going to save dollars. It's going to save us from repeating a CAT scan that might have been done, you know, 2 weeks earlier at an ER that we didn't know about. So I think there's certainly cost benefits to having the connection to that health care for that individual outside the jail. And we're still trying to figure out how to do it within the system, and that connectivity with the folks in the community, clearly important, but we've not gotten there yet.
And I think if you go back to the video, part of what Dr. Brenner is trying to do in Camden is rethink the role of the emergency room in terms of high-cost, high-need patients, that from his perspective, and I think now from the folks at the Camden County freeholders, the county administrator, and the county jail, they want the HIE in as quickly as possible, primarily because of the risk that the seriously mentally ill folks who are unmedicated, who progressively decompensate, until I can find out what meds they're on. If you haven't been in this jail before and you're arrested on a Friday afternoon, it's going to be Wednesday or Thursday. Before you get meds, you're sitting in a suicide smock, decompensating, smearing feces on the wall for 5 days, and posing a risk for every hour that you're let out. I think in that kind of situation, the HIE has very clear present value, but I think you're asking a bigger question than that, in which I think the value prop is still up in the air.
Any other questions?
Yeah, there's one on the right there.
I just would like to follow up on the...
Could you identify yourself?
My name is Cedric Hendricks, and I'm with the Court Services and Offender Supervision Agency, which is the federal agency in D.C. responsible for supervising men and women on parole, probation, and supervised release. We've got about 6,000 D.C. folks that are spread across the country in the federal prison system. So with that said, I wanted to follow up on the inquiry earlier about what the federal prison system is up to in terms of its own information, medical information, documentation, sharing, et cetera. Because I think it was just said that they have a system that's been in place for several years. But the question for us is, what is its accessibility to those in the community who are healthcare providers? And I ask that and offer an example. Unity Healthcare is a major community provider here. And I was in a meeting where they talked about trying to get medical information about a returned citizen that was at their reentry health center seeking care. And this guy did not have his medical records. He had served a long period of incarceration. They had to submit a Freedom of Information Act request to the Bureau of Prisons with the signed release in order to get this guy's medical records. Now, we have since that conversation seen Unity able to work out an arrangement with the Bureau whereby if they then, through a secured email channel, send that release to a particular person at the Mid-Atlantic Regional Office, that person will pull up what they need because they have access to it, and then send it in an encrypted secure email back to the point of contact at Unity. So that's a workaround that has been extremely beneficial to this community. But heaven forbid that poor lady at Mid-Atlantic go on vacation or die. You know, and not to say that the folk there at Mid-Atlantic won't try and figure out how to back that up, but that's a solution that is really not satisfactory, you know, in this community, given the volume of folk that we have locked up in that system. Now, we at the Parole Probation Office are trying to work out our own arrangement for similar reasons, because, you know, we get folks coming back to us for community supervision who've got behavioral health disorders that are severe and persistent, and physical health issues. And so in order for us, as we do our pre-release planning, to include continuity of medical care as part of that process, we need a certain level of information, which is hard to get because, you know, initially what we get are paper summaries that to some degree touch on medical information. And where you see something that ignites your interest, then you've got to call one of the 120 facilities where this person happens to have come from and say, hi, I'm from the Court Services and Offender Supervision Agency in D.C., and I'm calling the case manager, who's probably the one that put together the summary report, who not necessarily is in contact with the medical people in that same institution, and trying to ferret out through this telephone effort information that I need to help me understand what's in the summary document so that we can make sure that there are timely and appropriate steps taken to facilitate continuity of care when a person comes home. And there are some folk coming back who have some real behavioral issues who we need to have more than sometimes a couple of days or even a couple of weeks to deal with, because then, all these other issues we're confronted with, Medicaid, SSI, ain't in neither one of them, and some of the services out here you can't get unless you got somebody to pay for them. We're kind of left caught often flat-footed trying to deal with these extreme situations. So all that to say that it's great that they have a system, but people, since it's a national prison system, are in need of really having some kind of effective access to it so that we can get what we need to plan appropriately for people coming back to us. And we get about 2,500 that come back to D.C. a year from the federal prison system.
So what I find really interesting in what you're describing is not only does the workaround that Dr. Keldy was talking about exist within the correctional environment, that workaround exists back when these folks are back out on the street. And I think what that speaks to me is the extent to which, because we've created this unconnected correctional healthcare system, that what we keep having to figure out almost on a onesie-twosie basis is how do we build workarounds that let us provide the care these folks need both when they're in the correctional institution and when they're back in the community. And the nature of it is all workarounds. And so part of what health information technology offers as a promise, and I don't remember who was my skeptic this morning, but I had a skeptic, I think it was Dr. Stern was my skeptic this morning. I think part of what health information technology offers as a promise is the ability to not have to continually rely on those workarounds. Whether that promise will be fulfilled or not is, I think, another question. Any other questions? Yeah.
Yes, ma'am.
Joan, wait for the mic, Joan. We need a mic up here.
Yeah, I was just wondering, I know you're focusing on jails, and I know that coaches do, but because they're so separate and they're very autonomous, have you thought about trying to deal with the prisons first?
I think when we sit, and Carl and Ray, I'll be curious about this, when we sit, prisons are easier to routinize. They're much less chaotic environments. They're much more predictable. I don't have a booking issue on, 3/4 of the folks coming in stoned out of their mind or don't know who they are because they're a little bit psychotic. So I think prisons are a lower hanging fruit in terms of routinization. I don't know what you guys think.
That's absolutely correct. And, jails are revolving doors. The average length of stay in jail is 14 days or something thereabouts. And the challenges that presents, health care of these individuals is immense. Again, prisons, they're there for a long time. You can get, when they're going to get out. In jails, they can be bonded out and get out within the community within an hour, you don't know it. So that's where certainly the big challenges are, and that's clearly where the IT piece certainly makes the most sense.
There are actually a number of prison systems in the country that are fully integrated with an electronic medical record. Michigan, Indiana, Texas, to name a few, and there's an important role. It's not the same turnover and risks that you have in jails. But you get parole violators right off the street into a prison.
Some jurisdictions.
You get people, there's ubiquitous movement within a 3,000-bed compound, and when you're going to pass meds and someone's moved, you need to know where they are. Right. There's movement between the different prisons. So I think there's a significant role in prisons, and not only for an EHR, but having the ability to coordinate and communicate between the different prisons.
Yeah. And also because they are often state institutions and the health IT coordinators is usually a state employee.
Correct.
It might be easier to connect them, at least initially, show what the impact is. You could look at the high utilizers, and then maybe it would be easier to move to the jail.
And I have one person in the state who's the director of corrections, unlike 3,300 sheriffs and wardens. Yeah, but that's not coaches' mission. So different story. Any more questions?
Yeah, Carl.
Go ahead.
We got two.
Go ahead, two more, and then you're going to have to.
Mark Stern. I want to amplify something that Carl said about the prison issue. And that is, take Washington State, for example. There is a tremendous amount, in fact, there's probably more coming and going of parole violators than there are of the stable population. So there are some state systems that have a significant chunk of activity that looks more like a jail than a prison. And so from that standpoint, within the coach's mission, we should not forget them.
Great. One more.
Hi again. I think there's kind of two separate issues here. I hear from everyone, and as someone who works within corrections, but also more broadly just in the health policy world, it's not just the jail and prison systems that are having the frustrations of the electronic health records. I think for those of us who are not IT people, I being one of those, there was this false idea that once people got on an electronic health record, you could automatically share that information among different kinds of providers and organizations, and you can't. I'm hopeful that we will get there, but I'm going to have no role in that. That is, I'm hoping ONC and some of the other, huge pockets of federal dollars that have invested a lot of time into doing that will get us there. But I think the important thing is that if we don't get jails onto an electronic health record, they miss that train entirely. So let the feds work about making them be able to, because yes, there's a huge need for Homer at Rikers, when he gets someone, be able to stick a straw in the data stream of the surrounding hospitals' electronic health records and the community health centers' electronic health records. We're not there yet. I don't know when that will happen, but I do think we'll get there somehow. But I think the important thing is that if we don't participate at all, then even when it gets there, jails are still going to be in their siloed island of disconnected care.
Yeah.
And that, I think, would be a shame.
Well, Cynthia, that's why we're having this conference. That's the conference message. You got it. Thank you.
Good, I got it.
Michael, lunch.
Okay, one last question.
Go ahead.
Okay, so stay tuned for this afternoon, because what we're going to do is take a look at a system that's being developed in Baltimore with Greg Warren and his crew that is much further along down the road on this issue and can probably address some of the concerns that we've been talking about. What we're going to do now is break for lunch. I know everybody's excited about that, so we're going to break for lunch, and it's right next door to Thunder Grill here. We're going to go in there, and the table should be set for us, so you just pick a seat, and it's upstairs on the second floor over here, Thunder Grill. We should be starting at around 12:15, and we'll be back here at 1:15. Okay? Thanks.
Thank you all. We chose our after-lunch session for what most people think is the driest and most challenging stuff, which is talk about privacy and confidentiality. As Dr. Brenner said in the video documentary we viewed this morning, we're trying to contain spiraling healthcare costs, and we're trying to address the quality we provide at the same time. We do this in all healthcare settings. We've talked about how we're trying to do this in jail as well. In jail, safety and security come first, but I think for those of you who are not familiar with the extent to which safety and security trump privacy and consent, I'd like to provide an example. Jen, you're right up here in that second chair. Great. A Wisconsin district court ruled that it's perfectly legal to post a sign in big red letters that says HIV positive inmate on top of someone's cell. Needless to say, this would not happen in the civilian world. HIPAA and 42 CFR contain a series of safeguards so that individuals can protect their private health information through a process that we generally call consent. The population in jail is very different than the civilian population. They're younger, they're poorer, they're more likely to be male, they're much less likely to be literate. I think in DC, 50% of the guys in jail can't read at a 4th grade level. They have to constantly follow instructions, and these instructions are issued by guys with guns. This raises a very interesting policy question, which is how does our concept of consent in the free world fit into a jail paradigm? To help us explore this issue, we've asked 3 speakers to join us. Janet Root is president and CEO of the Utah Health Information Network. Throughout her career, she's been focused on the business aspects of bringing electronic commerce practices into healthcare communities. She has been deeply involved in making the Utah Health Information Exchange one of the leading HIEs in the United States. She probably knows more about integrating administrative and clinical efforts than almost anyone in the state HIE community. Melissa Goldstein is an associate professor in the School of Public Health and Welfare at George Washington University. She teaches courses in bioethics, health information technology policy, and public health law. She's worked as a legal consultant to President Clinton's National Bioethics Advisory Committee. She's been a White House fellow and a domestic policy advisor to Vice President Gore. During the 2010 to 2011 academic year, she was a senior advisor to the Chief Privacy Officer at the Office of National Coordinator. So this is a topic which Melissa is extremely familiar with. Paul Samuels is director and president of the Legal Action Center, a nonprofit public issue law firm specializing in legal and policy issues reference to substance abuse. Paul has been on many national and state advisory committees, including an expert panel for CSAP. And with that, I am going to turn it over to my panel by asking you, Jan, a question first. Okay. That's why you're sitting there.
Okay.
And so my question is, in Utah, you have one of the most advanced HIEs that you're going to lead us through a slideshow briefly to talk about. Yet, one of the questions is, as you deal with your members and exchange of information, are they comfortable with the information coming out of the correctional environment? How do they feel around the consents and whether they're valid or not, and how does that play within their own environments?
That's a really good question. And right now, we don't have the correctional facilities hooked up. So that is going to be one of the issues. I mean, I told you when I came here I was going to be learning a lot, and I really am learning a lot about the correctional systems and how health information exchange could be integrated into it. I always believe, but particularly now believe, that it's critically important that you give people who are in jails or prisons the ability to make a choice about do they want their health information shared or not. The Utah Health Information Exchange, it's called the Clinical Health Information Exchange, not a very original title, the CHI for short, requires patient permission to share data through it. So I think that that's going to be a really interesting thing. I know that there's a number of the behavioral health entities in the state are forming these primary care, behavioral health integrated clinics, sort of like a medical home kind of a thing like you were talking about earlier. And they are very eager to get this off the ground. So they've been a big push for me to basically try to figure out how to crack the 42 CFR Part 2 nut, because that's a very hard nut to crack from an HIE perspective. So I'm going to present a couple of ideas. I don't, in terms of the data, I mean, there's sort of two issues, data quality.
Right.
I think
data quality and transferability.
Yeah, transferability. And I got to tell you, I was laughing about all the interoperability issues because they're sort of bottomless, but that, from a technical perspective, that aside, basically what I think will happen is that physicians and the hospital systems will accept data from the correctional systems with the same pound of salt, and that's really what it is, that they accept data from anybody. Mm-hmm. It's largely based on, have you worked with that system much? And so do you have any sense from past history of the quality of the data coming out of that system? So that, I think that the answer will probably be a qualified yes. Okay. However, the whole permissions issue, I think, is going to get, how does an inmate, and I have to confess, I was talking with Pat Fleming, and he's like, well, there's pre-adjudicated and adjudicated, and for me, that's talking about claims processing, which is a totally different ball of wax, and I'm like, okay, same word, different meaning. So, that's an area of complexity that I need to learn more about.
Okay, so tell me how you're going to crack this nut.
Well, actually, I'm going to show you that in the slide.
Okay, show me how you're going to crack the nut.
You want me to do the thingy now?
Yeah, let's do it.
Okay, all right. Let's see if we can get this technology to work. Technology is great when it works. So, okay. I want to thank everybody for inviting me here. As I said, I'm one of those techno people, and I don't know much about the correctional facility, but I'm really committed to the potential equalizing power that an HIE can bring to a society. I think it's a really important thing to pursue. So let's see. So do I push the left button or the right button? Not that one.
There you go.
There we go. Just a little bit about my company. We're a not-for-profit company. Our mission is to reduce healthcare costs and improve the quality of care by operating a secure statewide network that exchanges standardized messages. We have both administrative and CHI. We're going to talk about CHI today. The goal here is, with patient permission, to connect all the dots. That's what we're trying to do, is to make a system that the data can follow the patient around with their permission anywhere in the state, and hopefully, eventually, anywhere in the country that they want it to go. But that's a huge problem. That'll happen after I retire. But I'm going to start within the state. That's my personal goal. So the CHI, again, not everybody knows what the health information, that the video that we saw earlier, I think, is one of the greatest concise definitions of what an HIE does. And if I'm talking to legislatures, I say it connects the dots, right? So people can get that connect the dot sense. When you see multiple providers or when you're in an emergency room, that means that that data that's so critical about you that was collected by some other doc can be available with your permission at that point of care. So what I wanted to briefly talk about is HIEs have many different consent models. You know, under HIPAA, a consent is not needed by federal statute, and Utah is a HIPAA state. We have our basically HIPAA is our privacy and security law. Consent is not needed to share data for treatment purposes. However, my board, and I think most of the citizens of the state of Utah would agree that it's the right thing to do, is to ask people, do you want to share your data through this health information exchange or not? So we do. We ask people. Most people choose what we call participate, which means you're in, and it means all the data that's about you in the HIE is shared. We're going to talk about the 42 not here in a minute, but basically all your physical health stuff is shared. People cannot participate, and we have this gray zone called limited, which is your data is shared, but only in two situations. One, if it's an emergency, and two, if you give that doc that day permission. Okay, so that's for those. About 5% of the population in Utah really want to micromanage that data. Fine. You want to micromanage it? You can. So the hardest nut, as one of my board members called it, we're developing two approaches to figure out how to allow people who are part of the substance abuse community to be able to share their data if they want to through an HIE. So basically direct, they didn't really talk about direct very much, but direct is essentially secure email. It's been brought up here before. Everybody with a direct access has their credentials verified. So all the docs, we verify that they're a doc, that they're in current good standing, they've got a license to practice, all that sort of stuff. It goes into your existing email. You'll hear people like ONC say it's easy. It's not. Nothing in HIT is easy, and anybody who says it is selling you something. But it's not. But it is doable, and we do have it in production. So basically, you have to know who to send it to. So the position of the Rikers gentleman who's having to call his local hospitals to see, do you have any data on this person? It doesn't solve that problem, but at least creates an audible, secure way to exchange that data other than through email or fax, which is really pretty awful from a privacy perspective. Now, work groups actually is an HIE function. A work group is essentially a clinic or a hospital system that the patient can choose. So they can choose to participate, which means their physical health information is shared by anybody who's treating them in the HIE. But then they can say, this one clinic also gets my Part 2 data. Okay, so you get the Part 2. This is a proactive approach, right? The way I've been thinking about this with the people in Utah. The Part 2 facility collects data in advance. Okay, so it's not waiting for that other person to come tap on your door to get data. It's like, okay, we want to direct you to your patient-centered medical home, whatever. You want to make sure that person or your jail or your prison or whatever can see your data, and vice versa. If you're coming out, we want wherever you're going, they're my clinic. I want them to be able to see my Part 2 data. Oops, here we go. So you can say, those guys, no, they don't get to see my Part 2 data. So you get to pick. And this is, we have run it through the Legal Action Center. They've said, yeah, this looks like this will work from a legal perspective. And so hopefully what will happen here is that you get all of these people can see all of the physical health information about a person if the person opts to participate. But whoever they choose as their work group for their Part 2 data, they get to also see that. So the only thing I want to say, and I guess we're going to talk about it here, is what are the additional issues, and consent is certainly one of them, Steve. So we'll leave it at that.
Great. Thanks, Jen. Well, Melissa, you've been working with the Privacy Office at the Office of the National Coordinator.
Yes.
So I think you've been out there in the federal level, particularly in these issues in privacy and consent. Have people thought about the distinct environment that jails are? How does this fit into this overall federal paradigm of policy and consent, and is it important?
Yes, it is important. Yes, people are thinking about it. Yes, people think it's an important issue to tackle, and as you heard from Judy Murphy this morning, right, there are things that need tackling. What is that saying about an elephant and biting off pieces of the elephant, but chewing pieces of the elephant?
Bite at a time.
This is a huge enterprise, right? And right now, ONC and the federal government is trying to get providers to adopt EHRs to begin with, right? Many of them for the first time, many of them like Judy Murphy herself, maybe in the 5th, 10th iteration of new software, like all of us have been, for the past 20 years with new software, updating all the time. It's a hard job, right? So doing a little bit at a time, people know that the correctional environment has to be tackled. The question is when, how do you do it right? How far behind does corrections get, right? So I don't think that it's a good thing to completely ignore the environment right now because it'll get too far behind. But then again, the farther we get along with what works and what doesn't work, we know a little bit more, and so we're not really experimenting, with little quotes around in the correctional environment like we are kind of where we are now. We're building standards now. They're building languages, right? How many of you had heard the term loink before this morning, right? So it's a language. It's a language that people have to exchange. So while we are building all of these languages, no, jails have not been the first places on people's mind. But then again, how often are jails, right, the first implementation of any new technology, right? And then it's a much larger policy question of whether jails, prisons, the correctional environment in general should be a first location for implementation, or if it should come along as we perfect other methods. It's a big question, right? We want to do it right. We don't want to screw up in those populations. They've already got a lot of trouble as it is, right? But we don't want it to get too far behind so that it's a completely forgotten system.
I think one of the things that I was struck, Jan, by your talking about how your board had decided that even though technically you don't need a HIPAA, that it was necessary to do that. As I travel around and talk to different folks who are at different stages of trying to build infrastructure, what I hear is a lot of conservatism on behalf of HIE boards and local HIE folks in terms of the threshold of consent that's required versus the threshold that they want. And I think your thing on how your board is insisting that folks have an eyes open HIPAA disclosure, consent, not just a disclosure, is an example of that. How does that level or that threshold of awareness fit within that jail paradigm where it's perfectly fine and legal to put HIT positive inmate on top of somebody's door and they're wandering around with guys with guns saying, sign this?
Right. I argue with you about this a little bit, Steve. It is not perfectly fine and legal everywhere all the time to put the sign on the outside of the jail, right? So one of the things that, we often...
In Wisconsin, it's legal.
Right. In that little... Right. But you guys know how law is, right? There was a particular legal claim at issue in that particular case, and that particular plaintiff brought, a constitutional claim or a claim by Wisconsin law, which has nothing to do with HIPAA or with Part 2 data or anything. So it's... from the federal level, there really is no control over that piece, right? So HIPAA does not apply to everybody. HIPAA applies to covered entities, right? And it's it is a complex structure. It is a very, narrow area of the law that some people are very good at, right? And most lawyers want to have nothing to do with, right? Somewhat like ERISA, right? People don't want to have anything to do with ERISA. So I bet your lawyers know a lot about it now.
Oh, yes,
right?
we do.
Exactly.
We sure
So
do.
you learn more about it. It is not insurmountable, but there are a lot of perceptions about barriers that HIPAA puts up to sharing information in general, health information, that are really perceptions. They're not actual legal barriers. And it's a lot of fear about doing something wrong. Are we going to violate the letter of the law by doing something wrong, by not including these people in our exchanges, where perhaps it would be allowable, certainly if you do it right. And so what we try to encourage is the study, the do it right? So, the Office of the National Coordinator has put out a tremendous amount of information just for those small providers out there, the RECs that Judy mentioned this morning, right? Trying to help people through these barriers. We don't want to put unnecessary barriers to sharing information, but we also don't want the horror stories either, right? But one of the bad consequences that I could see coming from this is not including behavioral health information, not including substance abuse information in the exchanges, not including the data of those prisoners, those inmates who want to be included, right? And that, because there are tremendous public health benefits and personal individual health benefits that could come around. In terms of doing more, allowing more consent, I'm all in favor for that, right? The more power that the individual has over sharing his or her information, the better. Correctional environments are a little different when it comes to, what other people need to know about you for the safety of yourself or for the safety of other people, guards, other inmates, things like that.
So you led me right into the question I want to ask you, Paul, which was this whole question on behavioral health providers and perception. So you guys are at Legal Action Center, represents a lot of behavioral health providers. I think that increasingly folks are seeing value in HIEs, despite all the challenges that we're going to talk about, and we're going to talk about more of them. How do the community providers have concerns about the validity of consents within a jail setting? Is that something you're hearing, and how do you respond to it?
Well, first, let me just say that I completely agree with what my colleagues have said here, that it's crucial to get these records into electronic systems eventually, and maybe sooner rather than later. And this is an issue in the community as well as inside the facilities. We have the same concern about making sure that substance use and mental health records get into community HIEs as we do that they be linked and included in the jail settings. One of the things I think that's important to folks, actually two things that are really crucial to keep in mind. One of them is that, and we've talked about it a little bit already, but I think it's important to really highlight it, is that when we come to these issues about information that's more protected than the regular quote-unquote healthcare information under HIPAA, we are certainly talking about 42 CFR Part 2, which covers alcohol and drug records, but we are also talking about, and Melissa was alluding to this, we're also talking about state laws that are often very similar to 42 CFR Part 2 in that they require heightened confidentiality protections, usually consent forms, in situations even where HIPAA does not. And that comes into play for HIV records in many states, for mental health records in some states, for domestic violence records in some states. So the challenge that we have in HIEs, whether inside jails and prisons or out in the community, is not just about the substance use records under the federal law 42 CFR, it's also about these state laws, which HIPAA says must be obeyed, that HIPAA sets a floor for privacy and confidentiality, but not a ceiling. So we know that, and it actually, this in a way makes it all easier because we know we're going to be having to deal with heightened confidentiality protections in most states for a variety of things. And second, I also want to echo, as Jan said, that we know that this can be done. We know it can be, and it's not easy. None of this is easy, that's for sure. We've been working on this. But we know it can be done in two senses. And one is the one that Jan mentioned, which is technologically. It can be done. But we also know, and this, my roundabout way of directly now answering your question, Steve, is that we also know that consent can work in the jail setting and in the prison setting because we've been doing it for a long time. 42 CFR Part 2 has been in place since the 70s, and soon after it went into place, there were opinions that were issued by HHS's counsel's office that said that where the definition of a substance use program, an alcohol and drug program, was met, whether that was inside a jail or a prison or not, 42 CFR Part 2 would apply. And essentially what that definition is a two-part definition. Is there a healthcare program that's providing alcohol and drug services? And is it receiving some kind of federal support, directly or indirectly? So if there are specialized alcohol and drug services being provided, and many jails and prisons have special alcohol and drug programs, or they have people who are expert in alcohol and drug services who are providing them, then that meets half the definition. And most jails and prisons are going to have some form of federal support, financial or otherwise, going in one way or another. So as a result, we've been in a situation for many years, for actually many decades, where jails and prisons have had to follow 42 CFR Part 2. And they have done it. And that requires consent in a number of settings. It doesn't always. It doesn't in the same kinds of situations for people on the outside, like medical emergencies. But it also doesn't in certain types of situations where administrative control of the program needs to have information. But getting specifically to your question, we know that there's a lot of misinformation, there's a lot of ignorance, there are a lot of people inside the jails and prisons and are running the programs or running facilities who don't know the rules. There are also a lot of people outside in the community, including in alcohol and drug facilities, who may not understand the rules. But the same consent form works. It can be used in the jail and prison setting. And even though people have this idea that, well, can it really be consent because somebody's in a coercive environment? Well, the answer to that is that it's pretty hard to overturn a consent form once somebody has signed it. There are all kinds of circumstances in which it may seem like in a regular world sense that there's some element of coercion. But that's not the standard for invalidating a consent form. So by and large, consent forms are almost impossible to overturn once they're signed. We have very rarely encountered a situation where people even try to do that. And they work and they have worked. So if they can work in the old style technology, they certainly can work for electronic records where, difficult as it is, there's even more flexibility in how to set things up.
Well, I really appreciate that. And I wanted to try to leave lots of time for questions because it's very unusual to have two such legal experts and someone who's actually working on this in a state environment come together around this very thorny issue of consent and privacy. So questions from the audience. Boy, they're letting us off really easy. Yeah, up here, Matt. Oh. You got one on that side too? Go ahead.
Yeah. I've been Butler from Coaches. This is for Jan. It's more of a connect the dots question for me. When you're talking about using direct, are you implying that the consent is given and then the doctor will send it to another doctor, the record over direct? And what about expiration and things like that? What you're thinking, could you fill it out for me, what you're planning to do with direct?
Yes. I work in an environment where there are a lot of different levels of comfort with risk. Let's put it that way. And direct is essentially, I think from a legal perspective, a substitute for fax, except it's better.
Yes, yeah.
But it's basically a fax, okay, except it's secure and electronic, yada, yada. And some of my members that's their comfort level. They want to basically take the current process of somebody, if I'm sharing a patient with you, I'm the Part 2 entity, that patient comes to you and you say, then you come to me and you say, I want the Part 2 records, here, Steve has signed the consent, and I look at it and I go, okay, and then I fax you those records. it presumes, it's a one-to-one communication. So from a legal perspective, some of my members are probably only going to be comfortable with that. What an HIE like mine does, though, is it allows you to query when we get all the dots connected, which will happen after I retire. But basically, when you get the dots connected, I can query the system, because the whole issue of the gentleman from Rikers saying, I don't know what ED I went to. It's very common. I don't know where I got the surgery. I don't know. So what do? So you try to connect this. Ours is a federated database, so it is a great big database, but it's a lot of separate buckets. You can query the whole thing. So you can get the physical data. If you've been designated as the work group by that patient, you can get the Part 2 data. You can get the whole thing in one fell swoop. Does that answer your question? Yeah. But it's a matter of risk. Some people are not comfortable with that risk.
There was a question on this side.
Hi, Greg Warren from Baltimore. So, in my opinion, I think electronic health records actually will enable us to have additional confidence that HIPAA and 42 CFR will be respected. And so let me just pose a scenario. As a former addiction counselor 20 years ago, I would have patients sign a release, and I would put a bunch of things on there. I'd put it in the paper file, and then 9 months later, I'd get a request, and I'd think to myself, I wonder if that release I signed way back, whether it covers this and whether it's still valid. And usually I would make it up on the fly. So now business rules can protect, that office clerk can't see that because they lack that ability to see that aspect of the electronic health record. Encryption, things get terminated through natural alarms that can be built into the system. So in my view, I like the analogy of the fax. This can be an electronic to electronic communication, that has other built-in alarms and business rules that can allow us to protect information in a much more secure way. Yes. So that's my first statement. The second thing that is a question that I've pondered is, how do you define informed consent? Because if I'm a clinician and I'm sitting in front of a patient and I say, okay, who's your PCP? Let's sign a release. Who's the Department of Housing? Let's sign a release. Who is entitlement benefits? Let's sign a release. How am I confident that I'm providing that informed consent? And the only way I can do that is if my organization talks to the other entity and says, how can I adequately explain the service you provide, and then offer training to make sure that that's informed consent. And you can actually build in a script in electronic health record that says you will say this when providing informed consent. So in my view, I think EHRs enable us to take a huge step forward and replace, frankly, a liability lawsuit waiting to happen.
So Greg, I appreciate that. I'm also familiar that you've been doing a lot of work with your agencies that form up your coalition, and I'm not sure that you have consensus among all of your partners about that. Could you talk a little bit about what the efforts that you've been going through to try to bring folks along to your perspective and what that's been like for you?
So in Baltimore, we've been putting together an electronic health record consortium. We've got 15 providers that have signed on non-binding letters of consent. These are mental health, behavioral health, PCPs, homeless services, and entitlement benefits organization. And they all are signing on to this EHR and going to be using EHR. But I look at it as they're using their own EHR. They have their own EHR that their agency is going to use, and if they're sitting in front of a patient and want to communicate information about that patient to another member of the consortium or to an entity in the UK, they still have to provide the same informed consent. They have to get the same signature, and so forth. So now, yes, it helps to have, a business service agreements or QSOAs, whatever the phrase is, but being a member of a consortium doesn't allow you an easier path out of informed consent or the responsibility to maintain it, in my view.
I just want to second a couple of your emotions because I think that you're absolutely right. We have felt this from the beginning that despite, or actually it's understandable that there's a lot of anxiety and confusion about how to make all this work in the electronic environment, and for good reasons. But when you work through it, as difficult as it may be, it actually does provide a lot more opportunities to make the system work. And in the way it was designed to work, where somebody gives consent, but then we want to have information flow whenever it's needed. So we have found the same approach. We've taken the same approach, thinking that this is the best way to do it. And then just one other important point about all this is that the opportunity for uniformity and for consistency is also much greater in the electronic environment, as you were talking about. I mean, one of the things that we used to deal with in the, I guess it's now I'm getting close to 40 years of dealing with these issues, is that one of the things we used to spend a lot of time on was helping people figure out whether their consent forms were valid and what needed to be in them, because even though there was a sample consent form in the federal confidentiality regulations that HHS issued in 1976, it wasn't all that well known. It wasn't as easy back then to get things around like that. And so we often spent a lot of time helping people craft their forms. Now it's easy enough to develop a standard form that actually everybody in the country could use. And that it just pops up. You have you explain to the patient that this is the form, a little bit about what it means. You have them read it. If they can't read, you read it to them. And you have a basic standard form that can be used consistently, not just across one HIE, but across a state or a country in ways that are much more effective to maintain confidentiality, but also enable communication than we've ever had before.
So we're going back to uniformity and routinization, aren't we? And I particularly like, Greg, your comment about the script, because I think particularly within a correctional setting, being able to embed that script within a correctional setting will increase people's level of comfort around the consent. There was a question behind you.
Just before we get to the next question, I just want to jump
Go
on
ahead.
the consent bandwagon a little bit.
It's what we're talking about. Feel free.
It is important for us all to remember, and we haven't forgotten it, that no matter how great a form is, the form is only a representation of a process, which ideally should be a discussion between a provider and a patient, right? And there should be an understanding about what's going on there. That's the information component, right? And it's one of the challenges of implementing consent. In ONC language, we would call this meaningful choice, right? We're trying to implement the choice on behalf of the patient, whether that patient is an inmate or not, right? One of the challenges in making this more mechanized is not having it completely done by machines, right? So that is a representation, so that it's not the form that's important, it's the discussion behind the form, no matter what environment that is. Right. And it's just as much a mistake, I think, to assume that you can't have proper consent in a correctional environment because of the location, as it would be to assume that it's automatically a real consent. That's a great point. Right? Because inmates can make their own decisions too. We just want to make sure that we enable them to do so.
You've seen one, you've seen one.
And in the real world, where we're implementing consent in clinical settings largely, typically it's not the doc who's talking to the patient. Right. It's the front desk person. If that woman thinks this is a good idea, I mean, 99% of her patients will go, yep, I want to participate. If she thinks it's a bad idea, then, most of her patients will say no. So it's like,
But if that person, can explain it and have a communication and an understanding, it doesn't have to be the doctor. In the clinical environment, it has to be the provider, the doctor, the nurse, the PA, whomever, right?
Right,
yes.
Great. Right. Okay, question. Where was it? Who was it?
Yeah, here. So my name is Mark Elson. I'm from California, from Cali Connect. We are the state HIE entity in California, similar to Jan. So I have a two-part question, first for you, Jan, and then for others on the panel and in the room. We know that one common argument against the sort of opt-in policy that you and your board have opted for is the undue burden on providers in terms of an addition to their standard workflow. And so you've been through the process in Utah. What have you learned through that process, and have providers largely come around, or are there still intense pockets of resistance, and what sort of is behind that resistance? And then secondly, we learned a lot, or at least I have, and others who are not from the correctional world, about your processes and the intake process. And how do those of you here think that this sort of informed consent, perhaps during the intake process, would impact workflow? Would it be workable? And then HIEs that we work with would hopefully be able to integrate and recognize consent, or you could recognize a consent form that has already been filled out somewhere else.
I'll let you do the first.
Yeah, so the first one about the burden on the providers, that was a huge issue when the board decided to do opt-in. What we have found in reality is it's really all about attitude rather than time. Again, for the provider offices or the doc and or the office manager is a god unto themselves, they're sort of an unsung person in the provider's office. If they believe in this, they'll do it. And we have figured out many, many ways where it takes 2 to 3 seconds max. So the time element, the burden element, we can minimize as long as their attitude is right. If they're not for this, then it's very difficult, and basically people throw up all kinds of reasons why it's no good. But where the physician's office, we've got long-term care coming up in wards, home health, hospice, places where there's a lot of frequent flyers. Those are the places where many people are in and out of the healthcare system. They can see the value of this, and they are implementing consent in a very low-cost way in terms of the burden on the providers.
And I'm going to try your booking question. When you've seen one jail, you've seen one jail. I think part of what's happened in Camden as a result of making the film you saw this morning is the light has come on for them on why an HIE will add great value to them. So they will, in fact, be in the next several months implementing a read-only HIE system in their booking area in order to basically have far fewer seriously mentally ill folks sitting around in the jail in a suicide smock for 5 days posing a risk when they can identify that individual's medication and get them right on it. However, I think on the other hand, if you were to go, for example, to the Alameda County Jail, where you would find a different environment and a much more conservative sheriff, you might basically say, are you nuts? Do you know what our booking area is like here? Do you know how many people we book in a day? You want me to add a stop to informed consent and have them read this paragraph to them? Forget it. And then I think if you went to a third jail, you would say, sure, give me the form. You, sign. So I think if you have seen one jail, you've seen one jail. I think it's going to be very challenging to create a universality about how to do that. On the other hand, from the coach's connectivity piece, we see booking as a huge opportunity. We're talking about doing Medicaid enrollment at booking for that very same reason. And so I think that the question becomes, how does one convince the correctional authorities and the sergeant in charge of the booking area why it's in the interest of the facility to figure out how to change their assembly line? Jails, as we've mentioned, are extremely chaotic places, and the booking area is the most chaotic place in any jail. If you remember the data that Nancy Barrand provided this morning, something like 3/4 of folks that are processed in booking have an illegal drug in the time of their body at the time of arrest. They are not exactly tending to be as cooperative as the offender that you saw on the film this morning. And so I think that creates another level of challenge. I think it's a persuasion effort that we do one jail at a time, going back to Dr. Brenner's comments again at the end of the film, one community at a time, one jail at a time, and I think that's frankly how we're going to have to do it.
So one potential argument for why jails would want to do this. When you look at HIEs in an ED environment,
Sure.
and in a lot of respects,
jail's an
are
ED.
kind of like an ED,
Right.
maybe a little more extended term, but kind of the same thing, is HIEs reduce costs.
Right.
Because they reduce CT scans,
Right.
they reduce repeat labs, and then they reduce inappropriate admissions, which maybe isn't completely part of a jail environment.
No, it is, because that's the question of that this person who's off their meds, if I can find out what med they're on and
Right.
get them back on their med, I don't need to house them for 5 days.
Right.
I never have to bring them upstairs.
Right, and so from a financial perspective, I mean, there
Right.
was a study published out of Vanderbilt University last May, showed just for 16,000 people, not a really very big population, who were in the HIE, their ED costs were $1 million less.
Right.
Just 16,000 people, not a lot of people. So there are some financial
Oh, yeah.
carrots that you might be able to offer
That's what we're doing. That's what turned the switch in Camden, was the light, making the film turn the light on. But I do think it's going to be very difficult to scale that because of the unique environment that different jails face. I think that as we turn towards Medicaid and Medicaid enrollment, I think that will be the opportunity that we see to bring folks into consent at booking because of the high value of doing Medicaid enrollment at booking, but that's another conference. Devin, do you want to get Devin, Philippe, and then we'll keep going.
Hi, Devin McGraw from the Center for Democracy and Technology. It's been a very interesting conversation. So I'm going to jump off the consent bandwagon, which is to say, I actually think it's an important thing to focus on, particularly in the context that we're talking about here. But I think it's a mistake to focus only on consent when you're talking about creating a trusted environment of information sharing that protects privacy, respects confidentiality, and also includes security. I do a lot of work on healthcare privacy and have advocated for consent in some circumstances and said it's not necessary in others, and try to approach this issue from the context of fair information practices, of which the right of a person to have some choices about how their personal information is shared is only one. Mm-hmm. And by focusing only on the consent aspect, when so many people say yes, either because they are in a coercive environment, which is so often present in an incarceration context, but there's lots of environments in healthcare that are coercive, point made by the panelists, it's hard to rely on. You can rely on it from a legal standpoint, absolutely, I'm not disagreeing, but in terms of creating a trusted data sharing environment, you can get people to agree to almost anything on a piece of paper, usually generally worded unless a specific authorization is required, as opposed to thinking through very carefully what are the circumstances under which we're going to allow data to be shared, who's going to be allowed to access it, under what circumstances will we agree we will not share this data for reasons of encouraging people to come forward for treatment purposes, and that's why Part 2 not only has very stringent authorization requirements, but also some very clear limits on who can access that data and under what circumstances. So while I'm not suggesting that consent isn't something that you have to pay an awful lot of attention to, I think we do people a disservice by paying attention only to that aspect.
Interesting. There was a question on this side, and then there was one. Who had their hands up on this side? I know
if I can just make one interesting
go
comment
ahead.
that we're noticing about when we go out to health fairs and employee fairs, and we're going all sorts of places all around the state to educate people, because we believe the first step in consent is you need to tell people what this is, what their choices are, let them stew on it for a while, and then go talk to their healthcare provider, because I think you're absolutely right. It's very interesting. We were talking about this at lunch. In the under 30 crowd, their primary response is, don't you do this already? I'm definitely not under 30, but they seem to have very different ideas around privacy. Basically, my concept of privacy doesn't seem to be shared by them.
That's an understatement.
Okay, yeah. And I'm just saying the major, like I said, the major remark is people get angry that their data's not shared.
Okay. Interesting. Yeah.
You know, I think that...
Could you identify yourself, please?
I'm Albert Woodard with Business Computer Applications out of Atlanta. We do the work for the Salt Lake City County Jail.
Oh, good. Okay.
And have the EMR there.
All those guys
Exactly.
there.
And
Cool.
that jail has won several awards over the last years of being one of the finest run jails in the country. primarily because it embraces technology. I agree with the concept of consent because I think that we have to remember that the patient owns this data, number one, regardless of their mental capacity or their economic status, that this information belongs to the patient. Gentleman out of California, I'm not sure that intake is the place to be to do this process because in a jail setting, these guys are coming in real quick and they have alcohol and drug problems and mental problems at intake. However, they are going to be there for 14 to 17 days on average in a jail. And we have an opportunity to gain that consent in other places by people that are that the inmates depend mostly on. And that is the nurses that's providing the drugs and those kind of things while they're staying there after they have gone through detoxification. Some of the things that we're doing at Salt Lake City County Jail, for example, is providing the nurses with full tools that when they go out and provide medications, they can do all of the other nursing tasks that they have to do, and having consented those parts early on is a good possibility after detoxification. The other part that is a good place is at release time, because then they're certainly detoxified and they may have been counseled by a judge or an attorney or something like that and have been given their rights. Now, following that process on through, keep in mind that these ladies and gentlemen are coming in and out of this jail often. So in the course of a year, they're coming through like 4 or 5 times, some of them. And as a result of that, if we can have consent, something like Medicare and Medicaid, where you have to sign a consent form once a year or something like that, and then it covers all of your visits, that's an opportunity for us to do it because recidivism rates are so high. I think in Salt Lake City, it's between 40 and 60% of them are coming in at least 3 times in a 6-month period of time.
Mm-hmm.
So I'm an advocate of consent. I think that there are places where we can logically get those consents and be effective and whatnot, especially for that population.
So I just want to put in a little pitch for the Salt Lake City Jail while you did it. That Pat Fleming, the behavioral health director at Salt Lake City County, has actually been working to create what I would call as a web-based shared behavioral health system that they put out an RFP from, and they're having problems getting bidders, which I think is a sort of an interesting statement in and of itself about where we are. But they're very active in trying to integrate the jail in their efforts. I have time for 2 more questions.
I would just, Steve Spencer, I'd just like to reinforce what a couple of comments have been made. The first few hours after admitting a jail inmate are dangerous times. That's when bad stuff happens. Suicides, deaths from drugs that have just been taken. So the consent information to be reliable must not rely on information obtained in those first few hours.
Great. Okay, there's a question. Go ahead.
Hi, I'm Allison Hamblin with the Center for Healthcare Strategies. I'm curious about how health plans, managed care organizations fit into this paradigm. This conversation has been really interesting, mostly focused on provider-to-provider exchange of sensitive, protected health information. At the Center for Healthcare Strategies, we focus on Medicaid, and a lot of our work is focused on improving integration of physical and behavioral health care in the context of managed care environments. And my personal experience with this has been that sort of in addition to federal law and state law, there's the interpretation of federal and state law by these key stakeholders in the system who are, on a case-by-case basis, very concerned about liability. And so I don't know very much about health information exchanges, and so part of my question for the panel is how managed care organizations fit into the HIE paradigm, how they connect or don't, or whether currently or in the future. And with respect to the consent forms and the privacy laws, whether from a legal or a sort of practical matter, how any of you see, again, kind of the managed care layer of the system fitting in here, especially in the context that, as my colleague said earlier, Supreme Court willing, we're looking at a landscape in the not too distant future where most of the jail population will be enrolled in Medicaid managed care organizations at some point in the continuum.
Jan?
Yes, I think I was around when HMOs were started, and now I'm looking at ACOs, and I think of this as sort of second verse, of the whole conversation. And there's a tremendous amount of interest among the Medicaid current HMOs going to become ACOs in Utah, because it solves a couple of the problems that HMOs stumbled upon and were not able to solve unless you became an IDN, an integrated delivery network like Kaiser or Mayo or Intermountain. And that is, if you have, what was called a gatekeeper, what's now going to be called a care coordinator, one, how do they get the data about that person, right? Even if you have an IDN, but they go to Moab, it's in Utah, it's a place to go ride mountain bikes, fall off your bike, break your head, end up in Moab Regional Hospital, which is a small county-owned hospital. Doesn't have connections with anybody. So how do you get data there? The HIE is definitely a low-cost way to do that. So there is a lot of interest in Utah for the HIE to begin to supply those kinds of services so that you can actually do the vision of an ACO/HMO without necessarily having to form a great big IDN kind of a system. Just real briefly, because this is really complicated, but one of the things we're discovering is that there's many flavors of consent, okay? Basically, the consent I talked about here is the patient's consent to share their data through the HIE for treatment purposes, okay? There's a whole other, and I'm just going to call it consent too, that happens when a patient signs up to be a member of a healthcare organization. Okay, that's not my consent. That is a legal arrangement between either their employer and the payer that the employer has selected to have their employees be insured under, or Medicaid and their clients or whatever. But that is a consent for sharing data to pay claims, for case management, utilization review, disease management. That's a whole separate ball of wax that I do not manage. Okay, that is between Medicaid and their clients, or the payers and their employers, and then the employers and the employees. There's property and casualty, there's workers' comp. I mean, gosh, it just goes on and on and on. And there's all different kinds of consents. But yes, short version is tremendous interest, tremendous opportunities for administrative savings. For example, the long-term care folks were spending $8 a pop to do certified mail for prior authorizations to Medicaid. Every single one cost them $8, right? Which is tremendously expensive. And we can now do it for essentially cost them, I think, $150 a year.
And that also feeds your sustainability model.
And it feeds sustainability. It provides them value, provides Medicaid tremendous value, improves their relationships with the providers so that what Medicaid pays for is much less of a hassle to obtain. So I think that there is enormous potential. There's some legal issues we're going to have to be very cautious with. And I keep telling the payers this. You've got to look at your contracts. You've got to see, do you think that those contracts are going to work in this new kind of an environment?
Paul, you get the last word.
Yeah, and I just wanted two other points to add about that, because it's a very important issue. One of them is that this is one of the areas where the law is different between HIPAA and 42 CFR Part 2 and some of the state-specific laws. HIPAA allows disclosures without consent for payment, but 42 CFR Part 2 does not. And some of the state confidentiality laws in other areas of healthcare do not. So that's another reason why, as Jan is saying, that HMOs, as they get into this, are going to need to understand this, but so are the HIEs, and how these payment mechanisms are handled has to be different. The second comment is a specific one for criminal justice, and that is that in our experience, a lot of the HMOs are really very, how shall I put it, not that familiar with dealing with the criminal justice system, and sometimes downright hostile, to the point where there are a number of managed care plans that will not honor, meaning they won't pay for, assessments and treatment that are done if it's court-ordered. And that is a problem in many places. It was a problem in New York 10 or 15 years ago, to the point where those of us on the advocacy side got New York State to pass a law saying that HMOs had to honor court-ordered assessment and treatment. And that's in the community, let alone what it's going to mean for an HMO to start dealing with a jail and prison environment when many of them haven't even wanted to deal with the community-based criminal justice system.
I appreciate that a lot. I want to thank you all for shining this light on this, and ask the next panel to come up. While we're waiting for the next panel, I just want to talk a little bit about how fascinating for me, and most of the feedback I got at lunch this day has been from the varying perspectives that we've able to bring to make the unseen providers seen from various different angles. And I want to especially take this opportunity to thank Nan Torrey, wherever you are, right next to me, for all the work that she's done in putting this meeting together. We could not have happened without Nan. And to thank my staff, Marie Leaf, Max Cuddy, Philippe Levy, Matthew Bekele, and Julia Kaiser from Burness Communications for their efforts, and to thank Mary Darby from Burness Communications for all the work that she did in getting those papers to you that you had to read before this, as well as Ben Milder from Burness for all of his ongoing help in helping us think through all of these challenging issues. And that's thank you to all, and especially to Nan. With that, we're going to try and do some closing comments. I think the order of operations is Keith. I need a fifth chair. Could someone put a fifth chair on the stage? Keith, you sit right there. Right. Can I have that fifth chair, please, sir? Keith, you sit right where you're sitting. Is Dr. Clark here? No. Not yet. So we'll save a chair for Wesley, and then Ed, and then Greg, if you would go at the end, that would be great. So let me go ahead and introduce our trying to make sense out of the day. Dr. Barton is the medical director of Coaches. He has a long history of expertise in correctional health care, having worked at the Alameda County Jail, which is the Santa Rita Jail, for several years. He's board certified in internal medicine and acupuncture and holds a certificate in HIV medicine. And at Coaches, we're very fortunate to have a jail experienced physician as part of our team. Dr. Clark, I'm sure most of you know, he is the director of the Center for Behavioral Statistics and Quality. Right now, he was historically the director for Center for Substance Abuse. Ed Harrison is the president of the National Commission on Correctional Health Care. He's been there, Ed, over 30 years? NCCHC has been around, not you, NCCHC has been around for over 30 years now?
Since the early 80s, right?
Yeah. And they have been the leading provider of standards and independent accreditation of correctional health services. And finally, I want to introduce Greg Warren, the president and CEO of Baltimore Substance Abuse Services. And I think the format for this is I'd like to sort of ask each of you guys a springboard question, if I could, to do that. And so I guess, Keith, what I'd like to ask you is we spent a lot of time today talking about routinization and the relationship between electronic systems and predictability and routinization. I know part of the work that you've been doing has been trying to decrease variability between jails and looking at best practices as a way to do that. Could you talk a little bit about some of that work?
Thank you. Well, as many speakers have noted today, jails are frequently chaotic environments. And in addition to that, there's a great deal of variability between jails in terms of their size, their staffing patterns, the level of information technology that they might be utilizing, treatment protocols that are utilized in the jail for various conditions, the therapeutic resources. Some jails might have an have an infirmary, and some jails will not. And there are also variations in budget constraints for the different counties that the jails operate under. So to make the best use of health information exchange, there needs to be some attention to reducing the variability. And one of my projects at Coaches has been directed at developing some best practice proposals for healthcare in jails. These proposals would hopefully decrease gaps in the care in the jails, improve predictability, and routinize healthcare screening, mental health screening, connectivity of care and follow-up of care after people leave jails, and improve access to treatment in the jails. These steps are necessary to promote smooth information exchange between jails and communities, and I think these are themes that other panelists are likely to represent as well.
So we have best practices in prisons. We really have not had best practices, clinical practices in jails.
That's my understanding, and I think that's a reflection of the high level of variability between jails and the reluctance to impose that variability on jails. Although, as you've been saying, health information exchange shines a bright light on what happens in jails, and that in turn increases the value of having more routinization.
Right, and best clinical practices. I think the other thing that you haven't mentioned is part of, you've been doing this, is trying to take some best practices in the community and to the extent that you can adopt them to jails, and that hasn't been the easiest fit.
Well, again, the staffing levels and also just the intensity of activity in the jails is an impediment. You know, if you have 25 people arrested on the evening shift, unless you're in New York and can afford to have a 4-hour intake process, the pressure is to get people in and out.
Yeah, quite a different thing. Ed, you've been working on developing a different perspective on routinization. It's on the outcome side. So if part of NCC being an accrediting agency, it's my understanding that what you've been doing is trying to develop a whole series of healthcare systems that have outcome measures to them. And could you talk a little about that and how that fits with some of the efforts of NCQA, the National Commission on Quality Assurance, in terms of their outcome measure efforts?
Sure. I think everyone recognizes that electronic health records are coming to corrections someday. Question is how long it's going to take, what form it's going to take, and what are the incentives for a correctional system to develop an EHR and participate in health information exchanges, and we've been discussing that throughout the day. From our perspective, and it's true we are an accrediting body, but we're about quality improvement, and our interest, well, our belief is that we can't wait for an EHR to solve problems or health information exchange. Something we haven't talked about much today at all, if at all, for those outside of corrections, is a recognition of the deep and ever-present presence of the threat of lawsuits. Risk management is an integral part to managing a correctional office, a sheriff's office, a department. So there are 3 ways to get things going, or there's maybe a bunch of ways, but 3 ways to point out. One is you could pass a law. If the law says something has to happen, the correctional agency, the sheriff's office, is going to follow the law. The other way is to dangle the carrot of dollars. And if there are federal dollars attached to it, and this is going to be a way to supplement or augment or replace dollars from the county level, that's going to be greatly appreciated. The third is value. If there's a perceived or evidenced value in initiating an activity, then people are going to do it. And in the context of not waiting for an EHR to come into existence, we formulated, for a number of reasons, this idea of establishing CORDS, which stands for Correctional Health Outcomes Resource and Data Set. The idea being that it would provide benchmarking, which would be of value to the providers, either at the corporate level, the sheriff's office, or the county commissioners, whoever is asking for those data sets, to use in measuring just where we are. I talked about lawsuits earlier, and as many of you know, the state of California had long-standing lawsuits and health outcomes issues and ended up going into receivership with its prison system because of bad outcomes. And one of the things that the receiver's office tried to do was say, well, really, how bad is it in California compared to other states? Well, there was no way to compare. There was no standardization of outcomes measures for corrections. And that happened to dovetail with a report NCCHC done on the health status of soon-to-be-released inmates, talking about the burden of chronic disease and looking at outcomes in corrections. So we've established this program, which is developing quality measures, performance outcomes measures, based on NQF-approved measures from NCQA or others, but adapted as necessary for corrections. And the people who are participating at this stage of the program are developing the measures, as I say, and submitting data that gets reported back to them anonymously without any patient identifiable information, and used for quality improvement purposes. This, getting people to agree on the standard measures and used to reporting and sharing data in a comfortable way, we think is paving the way or making it easier to get to that point should health reform pass in its current status and the regulations come down and other things come into place where people are going to have to report or be encouraged to report.
So it's interesting. I hear both you and Keith talking about routinization and the role of healthcare technology in both paving the way and creating the opportunity for and creating a feedback loop in terms of routinization, and jail is a very chaotic environment. Hi, Wesley. It's okay, no problem. I think that the other part of the challenge of routinization, Wesley, it's perfect timing because I'm just my lead-in.
I was covering for you.
The other part of routinization, that's the challenge in this, has been that behavioral health care has been left out of meaningful use. And that we all know that within the jail environment, the number one issue that we confront are folks with behavioral health disorders. And if meaningful use, part of what Judy was talking about this morning, if meaningful use of standards are the vehicle through which we're going to figure out how we create routinization on a national level, and we know that the jail population is primarily a behavioral health population, then Dr. Clark, we're hoping you could guide us through this forest that's a clear sort of culture gap or dissonance between these two perspectives, which I suspect you are knee-deep in alligators in almost every day.
Well, actually, we are actually. As it turns out, there are a host of entities that are seeking access to substance abuse treatment records. And I think that's cause for caution. It's not just the criminal justice system, but it is also a lot of the public service entities working in the community, housing authorities, TANF, food safety authorities, child welfare authorities, et cetera. In one way, the jails actually have an easier approach in the criminal justice system because there are special exemptions to the criminal justice system or for the criminal justice system and negotiating the exchange of information. You have the person, you can easily get their permission to their consent, as it were, put quotes around the word consent. But the real question with electronic health records is who else has access to the information and how widely is it spread. Accountable care organizations, the question is, well, what do you do with the information? Because it's supposed to be a feedback loop. And 42 CFR Part 2 doesn't support feedback loops outside of consent. So, but again, the criminal justice system has a special exemption. The Congress felt that the criminal justice system should have that exemption. So the real issue, as people have discussed in the past, is having the systems in place where that information can be exchanged. Because there's a wide diversity of substance abuse treatment programs. So those are medication-oriented or medically oriented. And then there are those that are non-medically oriented that have a different set of information. As you know, as you pointed out, we weren't in the meaningful use criteria. So developing software that deals with the behavioral health phenomenon is going to be a touch-and-go issue. There are over 100 vendors and roughly 25 vendors who have Meaningful Use 1 certification, but most don't actually deal with the full spectrum of behavioral health issues that would concern the criminal justice system. You want to know whether someone's got a medical problem. You want to know whether they have HIV. You might want to know whether they have a history of violence or psychosis, et cetera. And it's not just 42 CFR Part 2 that we're dealing with. We have many jurisdictions that also classify mental health information as protected, and then there's genetic information that's protected. So there are a wide range of other issues associated with exchanging information. But both the criminal justice system and the substance abuse treatment systems have anemic electronic health records. So even if the rules permitted it, from a practical point of view, the resources are not there to leverage that exchange of information.
So what I'm hearing you say is we have sort of a resource issue, which is not a small one, in terms of doing this, and yet we have the most expensive, what tend to be one of the more expensive sets of patients that are in our nation's jails that have behavioral health disorders, and yet we haven't made the resource investment to hook them into the system. That's a little dissonant, don't you think?
Well, I think, obviously we're in this time of resource shortages, and I think people put a pause on this concern, so it's really useful to have this issue kept on the front burner, or at least in people's awareness, because there's this tendency when money is tight to bypass some of the most vulnerable, particularly associated with the criminal justice system, because of the underlying assumption that, of, quote, just desserts.
Right, and I guess Ben Butler this morning mentioned David Mancuso's data, which shows that investing in substance abuse treatment saves both healthcare and criminal justice costs. And I think it's important for those of you who are not familiar with that data, if you go to the library on the coach's webpage, you will find David Mancuso's data there. I want to encourage you to take a look at it, because I think this sort of frames the complexity of this discussion we're having at a high public policy level, which is we know that these services save money on both the healthcare and the criminal justice side. We don't know yet how to bring them into health information technology, and I think that's part of the challenge. Greg, I asked you to join because of all the folks who are in this audience, I think you wear the most unique set of hats. So I want to just describe the hats that I know about that you wear. You're on the state HIE board in the state of Maryland. You've worked within a correctional system for many years. You've worked being an addiction counselor in a community-based setting, and you now run a consortium of 17, is that my number right, agencies? How many agencies do you have? Well, whatever it is, a certain number of agencies in Baltimore Substance Abuse Services in which you coordinate and which you've been, in effect, building a linkage system out to the correctional health system through an electronic medical record system. And you looked briefly in one of your questions, but if you could tease out for us, I think you've got probably more street experience and understanding. We're all public policy nerds at different levels. Dr. Barton is the closest one of us, but I sucked him out of providing care in a jail and put him into a policy hat, which he grumbles about every now and then. But you're probably the closest one to trying to make all sense out of all this and all your different hats. Would you try and summarize for everybody where we go with this?
Sure. So just to clarify one point, the agency I run, my agency is the local substance abuse authority for Baltimore City, which is the largest city in Maryland and which gets 40% of all the public substance abuse dollars in the state of Maryland. We don't provide any direct services ourselves, but we fund 50 to 60 prevention, treatment, recovery programs, whether it be in hospitals like Johns Hopkins or very small drug-free outpatient programs or in elementary schools, that kind of thing. So that's what I do. So 20 years ago when I got involved in addiction counseling, not having been addicted, I asked myself this profound question: why are they here to see me? And then why do they want to keep coming to see me? That was the second question. And the third question is, when asked by my next door neighbor, why is it that I'm in this business and how do I know it works, right? And so it's that mindset that I've looked at substance abuse treatment, whether it's in drug-free outpatient programs, working with homeless, HIV, in the correctional settings and so forth. So what is it that they're coming to see us for? And they're there because they have a motivational moment. Criminal justice arrest, DSS, school, ER, something is driving them. Why is it that they want to keep coming to see you? Is because what I used to tell clinicians I supervised, you're only as good as your Rolodex. In other words, how you're able to connect that particular patient to a service that they perceive as valuable. All right? And so then, how do I explain it to my next door neighbor what I do, and does this really work? And they basically want to know two things. Is my grandmother going to get robbed by the drug addict down the street? And am I going to have to keep paying more taxes to take care of uninsured folks who are doing terrible things? Right? And so that's a very profound question. Now, the thing is an electronic health record system and the partnership between corrections and community programs actually has a profound way of helping all three of those issues. All right? Because the first is I will be able, as a clinician, to treat the entire person. They're there for a substance abuse problem, but if I have a consent, I can connect them to homeless services. I can connect them to entitlement benefits. I can connect them to the Goodwill agency down the street that's going to give them clothes. You know, I can connect them to this much larger world and explain the benefits of that connection through an electronic health record system. I thought the video this morning was terrific, and Steve, I also want to appreciate your leadership in putting this together. I think it's very invigorating to come. And that video, I think, really captured, even though it's based on Camden, Baltimore City's challenge. It looks exactly like Camden if you walk around the streets of Baltimore. And there was a profound moment in that video that, I don't know if many of you noticed, there was a patient that was rocking back and forth, and the clinician said to the patient, so are you going to make those phone calls? Now, I don't know about you, but many of my patients in the past didn't have the ability to pick up a phone and make those phone calls. It takes the clinician with a therapeutic rapport connecting that person to another entity, and the electronic health record system can be that vehicle. So backing up to why I first got interested in electronic health records is first to answer these sort of profound questions. The second thing is with healthcare reform coming in 2014, I knew that very small substance abuse programs needed to learn how to bill managed care and need an electronic billing system to be able to do it. That was the first thing. The second reason is that to maintain clinical and cultural diversity in a city where a community substance abuse program fits the needs of its community, and the way I describe it is I shop at my neighborhood convenience store. When I buy cakes, I go to a particular store that's within 2 miles of my house. We shop within the neighborhoods that we live in. We get sick within the neighborhoods we live in. We need to get healthy within the neighborhoods we live in. And we need substance abuse programs that reflect the clinical and cultural diversity of every neighborhood in our city. And without an electronic health record system, these very small programs spread across the areas where you work and live are not going to be able to survive. And so I felt that it was my responsibility and my agency to help provide intelligence to programs in terms of being able to purchase an electronic health record system. I had already seen small programs make bad decisions, purchase an electronic health record system, find out it was a lemon, and spent, in one case, $250,000, to replace it. The remarkable thing was the executive director kept her job, and the program didn't go under as a result of that bad decision. And so, programs on the community side don't have IT expertise and are set up for making really bad decisions. And so I felt the need to reach out and hold focus groups with providers to figure out exactly what they needed. The second part that is sort of a key understanding to this is that public safety and community programs both have a burden of unfair expectations. So when I was with public safety, our task was to rehabilitate people. And the Baltimore Sun headline would read, "Inmate just released commits another crime," right? And it's an unfair expectation, yet it's an expectation that's put on corrections. The same thing goes for substance abuse and behavioral health programs in that, how come you're not cured? You've been there 28 days. You know, shouldn't you be cured? And so both of us have this expectation of an unfair burden that I think is just really it's a travesty. The second part is substance abuse programs, because of bifurcated funding, because of sort of being the sons of somatic care, you know, are not connected to somatic care. And so we have argued that substance abuse programs should be a part of the public health system. And I think that's a case we still need to try to argue. The second part of the coin is correctional systems are a part of the public health system. And I challenge you to go talk to any warden, any department level secretary of a prison system, and they will say they're a part of the public health system. You know, inmates, as Ed addressed, or partially addressed, they're the only group in this country that have a constitutional right to health care. You know, and so when I was in corrections, we were making a tremendous investment in terms of assessment and treatment, and I thought it was a shame that we couldn't communicate that information to anybody in the outside world. What would be the benefit in terms of reducing criminogenic thinking and behavior if we were able to pass it on? I think it would have a profound impact, you know, on our society. The other part of the equation that both corrections and community programs, I think, share an equal burden is that we have to make the families of these patients healthier, and we have to make the communities in which they're returning healthier. And so with better effective community supervision, you know, I think, and the use of electronic health record systems with a DPP agent, parole and probation agent, you know, in partnership with a case manager at a behavioral health organization, in partnership with a PCP, that kind of combination can leverage incredible motivation for change and produce significant cost savings. In Maryland, we have encountered a great deal of support for trying to create this consortium, which very simply is we are, on a voluntary basis, programs will be buying into an electronic health record system, pay the user fee. I'm going to have local foundations pay for all of the implementation and training costs, and then it would be sustaining simply by programs paying, you know, a monthly hosting fee. But in a state budget, the two biggest cost drivers in a state budget are health care and incarceration. And so when you want to get a state's attention in terms of communicating to an HIE, you know, and saying to the HIE, behavioral health wants to be at the table and be connected, they are very open to that once you point out the fact of the public health crisis that behavioral health and criminal justice, that nexus creates, you know, for at least for the state of Maryland that I can personally speak to.
So, Greg, I have a question. You know, I really respect the work that you've been doing. We've been trying to do our best to coaches to help you out to the extent that we can. What I puzzle about is how much of this is your charismatic leadership and your very distinct role in crosswalking the public safety and community system. That you have a idiosyncratic situation where there was a new inmate management system bought that happened to have an EMR as part of it. You've been able to leverage that EMR out into the community system. Is that scalable in other communities, or is that an N of one because Greg Warren's who Greg Warren is?
So that's a great question. So let me tell you some of the things that I've encountered. First, my agency is a 501c3. We're an independent agency. We get direct state funding. I have a 25-member board. The City Health Commissioner of Baltimore is the chair of my board. I have everyone from the police commissioner, Department of Housing, you know, various state and city politicians, on the city council president, they're all on my board. So it's taken so let me back up. Public safety, they want to improve recidivism. since I work there, they do have a level of trust with me that I understand their issues and concerns, and that's helped a lot. The second part of it is convincing everybody on the outside that, oh, okay, if you get this EHR, then won't public safety somehow be the big brother and start data mining and figuring out, all of this and that? And that is a legitimate public perception concern, and so that's also something that I've had to be very conscious of. One of the things that is critical about making this corrections to community program consortium work is public safety knows that I will be their champion on the community side, that people will be contracting with Baltimore substance abuse programs, will be contracting with Baltimore substance abuse systems, and not with corrections. That if corrections decides to dump this EHR, go back to the dark ages, we will still exist as an electronic health record consortium. So it takes an outside champion to help communicate to programs. If you're the warden and want to reach out and say, I really want to communicate better with you, I think that will really not go well. And that you need somebody on the community side to be your champion.
That's a really helpful perspective, because what I'm hearing you say are several things. That in terms of scalability, there's got to be a level of trust that's a two-way street. That community folks have to trust that public safety isn't going to mine their data, because that undercuts their mission. But public safety has to trust that their interests are going to be represented at the table. And I think that it's a very unique, and I'm hoping, as you know, we're hoping at Coaches, that it's a scalable model that you're putting in place where I'm having basically a fully linked system between a jail and the community with a behavioral health focus with no federal dollars from high tech, because it's not MU, right? It's all being done on a local basis of trying to build it with philanthropy propping it up. And it represents, from where we sit, about as far as anybody's gone in really thinking through what's the role of electronics in doing that. I think what I've heard from you over the past several months, Greg, is consent has been an issue, but it sounds to me like you're working that one out. It's a fair thing to say. It started out as a big issue, but I think you're most of the way there. That money has been less of an issue than you thought it would be. I think that's fair to say, because the community benefit is so high and so obvious to everyone that you've been able to bring in philanthropic partners to understand how it's in the public interest to sort of follow your lead in doing this. And that the underlying posit, going back to what we were talking about this morning, is that treating an underlying behavioral health disorder will result in less criminal conduct. And that resulting less criminal conduct will result in lower recidivism, and that ultimately that's the financial driver that makes the system work. And that to some extent, you're engaged in a sort of a real-world experiment to do that. There are a couple of risks that I want to put out on the table, some of which you and I have talked about. One is that for the first time, you will be able to look inside the black box of the substance abuse agencies that you fund. That you will be actually able to see what services they're providing, their relative level of efficacy, who lowers recidivism, who keeps people in recovery, and who doesn't. And I don't think we've had nationally, Wesley, you can correct me if I'm wrong, but I don't think we've nationally had this kind of natural experiment where I have what's in effect a fiscal intermediary being able to look into the black box and measure efficacy of all of the different styles of substance use disorder treatment that are happening in Baltimore. I think that's an exciting thing to happen, but I think it represents a community risk, and I don't want to understate it. Am I right, Wesley? We really haven't had that anywhere else?
You're right, but you also need to recognize that there are other dynamics going on. Accountable care organizations are also dealing with the issue of the multiple placements of an individual in terms of, because they're responsible for things like housing and food and et cetera. So human services agencies are working with healthcare agencies, and part of the thrust is indeed this holistic approach of managing an individual. And with the ACA, people who are vulnerable but who haven't committed crimes and who are eligible as single adults within the income range will be able to get health care services. But as I pointed out, there is a move afoot to discuss how do we involve housing and how do we involve employment and how do we involve food safety and child welfare, et cetera. I think what you have in Baltimore is a movement to anticipate that, but we do know some of the incentive awards, people are looking at vulnerable populations as a way of addressing these issues. Naturally, we'll have to wait and see how things unfold over the next couple of months.
That's correct.
If things come out in the right way, this whole process will accelerate and then there will be more interest. We are trying to encourage our grantees, whether they are reentry programs or drug courts, to adopt EHR. We can't require that at this point in time, but it's clear that the community has to recognize the utility, as Baltimore has, of having access to electronic health records. But you're just not communicating with the jails, you are communicating with a wide range of entities. The question of consent management becomes a critical question, and we believe that if you work with the patient, consent follows. But sometimes people want to treat the chart and not the patient.
Right.
So that's the limitation of that. So we have people saying, we don't want to be bothered with consent. We should have unlimited access to a person's information. And I think that's frightening to the community, particularly on both sides,
right,
which has less to do with someone's involvement in the criminal justice system and more to do with this sort of big brother phenomenon where all your information is at other people's ready disposal.
And the public housing issues and all that.
Public housing, et cetera. Right. So those are issues that we are struggling with.
Great. We have time for a few questions. We got to wait for my folks to bring up the microphones. I know Don has one up here. Could you identify yourself, Don?
I'm Don Murray with the National Association of Counties. One issue that we're very concerned about, and we're hopeful the new legislation will be carried out, but that we build on what we know is exciting. 2,400 counties in the United States have less than 50,000 population. There's a huge shortage of trained personnel. Like, we only have 1,000 counties that have at least one psychiatrist in the country. Most of them are on Park Avenue. I mean, if you walk on Park Avenue, there's about 7 each block. And then we only have at least 600 counties where they have one endodontist. So if you need a root canal, you're in big trouble. But what has intrigued me for many years is the Minnesota Community Corrections Act. It's aimed at trying to get the whole state together, rural and urban. So the vast majority of the United States is rural. There's the geographics of it. And unless we can encourage multi-county approaches, and that's what Minnesota does. They have a population threshold of 30,000. You can't get money from the state unless you bring in your neighboring counties. And they set up a multi-county system. It's not a building. They're not talking, they don't equate the correction system as a building. It's a system. And you can carve up that system into pieces. And the way it was conceived in my favorite consortium, Olmsted, Dodge, and Fillmore. Olmsted has the Mayo Clinic. So Olmsted claims they're in charge of health care. Dodge and Fillmore, 2 rural counties, they do other things. One thing that's crucial, we know that there are only about 400 counties that have pretrial service programs. So the initial assessment is very deficient in the country. The Justice Department estimates that counties could save $8 billion if they simply set up a sophisticated pretrial system. So as a result, 62% of the people in jail are there not necessarily because they're dangerous, but mostly because they're too poor to post bail.
Mike Jacobson's data bit is on any given night, there are 650,000 Americans that will spend the night behind bail to failure to have $500 to post bail.
So I would hope, and Steve, I want to congratulate you on picking such fine panelists throughout this program, but that the rural issue has to be addressed. I mean, the first time the federal government even counted the number of jails was in 1970. Right. You remember that? Yeah. When it made the front page of the New York Times. Yeah. It was such a revelation. Yeah. Revelation.
I appreciate that, and as I mentioned in response to Hugh's question, we specifically have been trying to focus on the rural issue, and we were sad that Dr. Campolo couldn't be here today to talk to some of his experiences. I have time for two other questions.
Well, I just want to point out with regard to HIT, both the Office of the National Coordinator of Health Information Technology below the Secretary's level and the Secretary's level are interested in fostering health information technology as a way of facilitating access to care both for substance abuse and mental health and physical health for people in rural areas. So HIT, especially with the advent of increased broadband, which clearly for many rural communities is still an issue, that we'll be able to do this. Now that's going to create some jurisdictional issues in terms of the criminal justice system, in terms of moving information, because a person, especially in your borders, may be receiving clinical assessment from one jurisdiction while they are lodged in another jurisdiction.
But we have models for that. We have a kind of multi-county agreements. Yeah.
So that's an important thing to keep in mind. We are concerned about health care in rural communities, and we're developing models at least to foster that and using multiple personnels like physician assistants, nurse practitioners, but who have consultation capability through webcams, the internet.
Right. And as we heard in our last panel, telemedicine.
Telemedicine.
Greg?
So I appreciate your comment about the difference between a rural setting and an urban one. The statistics I just want to share with you can pertain to both, but the role of a HIT, I think, can be very helpful for rural settings, particularly because there was a study done in Baltimore that showed, the average age of somebody in substance abuse treatment is 42. The age of first arrest was 13.8. The age of first crime was 13.8. Age of first arrest was 16.5. Age of first incarceration was 20.1. So in other words, people are touching the criminal justice system a vast amount of times before they ever enter substance abuse treatment. And so if pretrial did have an effective HIT system that could effectively divert people to whatever resources are in that community, I think there would be a significant cost savings, and we're just wasting that motivational moment.
So we have, it's very interesting you say that. We're actually in the middle of looking at how do you match a pretrial services program with a diversion to treatment program, and how do you scale those kinds of things, and what's the role of Medicaid in changing that paradigm? I think we all would be in agreement that that's sort of the next frontier in trying to think this through. Questions? Yeah, go ahead. Could you identify yourself, please?
I think addressing the rural area and things like telemedicine and other types of technology processes like that is that our attempts to make that technology work in order to address the rural problem has been solved based on having a record, an electronic record. Without the electronic record, we could not make telemedicine and other types of collaborative technologies work. And so that's why it's important that we deploy the electronic records as broadly as we possibly can, because without that chart, those providers that provide and clinicians that provide consultation can't do that without that documented historical information that the
and that's again another form of routinization, that by being able to create these records that don't have those hundreds of paper records that you saw in the film, we create a frame that folks can fit in. I think there was a question on this side. Is that correct? Great. Well, with that, I want to thank this panel a great deal. So just some closing words from me. In planning this conference, we recognize that health information technology is an evolving issue and that jails have not been part of this conversation. If you look at your participant list, you will notice how successful we were, thank you, Don, not only in attracting great and interesting speakers, but in attracting you, in getting those of you from different silos, electronic medical record systems, health information exchanges, correctional healthcare companies, public policy, philanthropy, criminal justice. You're all here in this room today to focus on this issue, at least for today. Our goal was to bring the right people in this room to raise and identify these issues that are important to integrating jails into healthcare technology. We hope that this conversation does not stop today, that jails will no longer be unseen providers, and that those vulnerable individuals who cycle in and out of our nation's jails will be visible in the health information system of today. In order to help us figure out how to do that, you all have blue evaluation forms in your packet. I'm going to ask you all to please take the time to figure this out. This is a particularly challenging question on how to go forward. I think that what you've heard everyone say is, yes, this is something we have to figure out how to do, but we need your feedback from your different silos to help us figure that out. And again, I want to thank the Robert Wood Johnson Foundation, the Public Welfare Foundation, all of you, and again, Nan Torrey one more time for having made all this work, and for all my staff. Thank you very much.